Good morning, sir. Is it audible?
Yes, it is.
Yes, sir.
Good morning, ma'am. I'm Dr. Jayalakshmi from Department of Preventive and Social Medicine, Jikmar.
Yeah, good morning.
Yes, ma'am. I'm very happy to invite you all for this plenary 6, ma'am, for the 65th Iphacon 2021. Ma'am, the plan of this session is I will formally invite the chairpersons. I will introduce the chairpersons. After I introduce, I'll hand over the session to the chairpersons. The chairpersons, Dr. Sutapa, madam will be introducing the first 2 speakers, and our Dr. Brigadier Saleh Singh sir will introduce the next 2 speakers. So at the end of this session, the chairpersons can give your remarks, conclusion remarks, and then we can conclude finally, ma'am.
Okay, I think Dr. Zila Singh is the co-chairperson, no?
Yes,
So after you introduce me, then I will introduce him. Then I will just give the opening remarks and then ask him to introduce the first speaker. Then I will introduce the second, he will introduce the third, I will do for the fourth. At the end, I will request him to sum up the findings and the lessons that we have learned from the presentations. Then we will invite questions from the participants if there are any, and at the end we will then conclude.
Thank you, ma'am. Thank you.
Okay, can you please enable the share screen option so that I just want to see whether I'm able to upload all the PPTs?
Yes, ma'am. We have enabled the share screen.
Okay, I'll just see because I'll have to display all the presentations. I just wanted to check whether I'm able to do so.
Okay, okay, okay. अभी इस प्लेटफॉर्म पे तो लाइव नहीं गया ना? नहीं नहीं अभी नहीं.
So all the PPTs are visible, no?
Yes, ma'am.
Fine, thank you.
Ma'am, all PPTs were visible. Ma'am, CV PPTs you will share or we will share from our side?
Now all those I'll share from my side.
Okay, you will share. Sure, ma'am. Thank you, ma'am.
No, sir, we have not yet started. Maybe you can just check your voice if we are audible and if you are also audible to us. Dr. Ashwag?
Hello.
Yeah, I can hear you clearly.
Okay.
Dr. Rajesh, yeah.
Yeah, hi Sutapa, good morning.
Good morning. Yeah, you're also audible, visible. Dr. Anuradha? Dr. Ashwag is also here. So can you just speak for a moment? We know whether you are audible to all of us.
Hi, Sutapa.
Hi. Your
Am I
video,
audible?
you are audible but you are not visible.
Yes, I'll make myself visible.
Ashfaq, can you hear now?
I think you can remove your earphone, that would be better.
डॉक्टर अनुराधा गुड मॉर्निंग. थोड़ा सा लेफ्ट हो जाओ. डूज ज्यादा नजर आने चाहिए, पीछे डोंट ज्यादा नजर आ रहे हैं. जस्ट
बीच में आ जा. हाँ.
ठीक है.
राजेश भाई, आपका भी कुछ सजेशन है मेरे लिए?
मैंने तो पीछे अपने वो रिलैक्सेशन के लिए लगाए हुए अफ्रीकन वो है, पीपल आर डांसिंग.
That's from Kenya, I think.
नहीं केनिया से तो कुछ और लाए थे.
I know.
आपका ठीक हो गया सर, डॉक्टर अशफाक? I can't see Dr. Zila Singh. He's not picking up the phone either.
Then I think the show is yours.
No, I called him yesterday. He was there. Today morning, he was not there. I tried calling him now also. He's not picking up. Yeah, he's connecting. Dr. Zila Singh.
Good morning. Can you hear me?
Yes, loud and clear. क्या हो गया था? You change your system or what?
हाँ जी.
अच्छा.
I had to restart it again and almost complete. So I think now it's done and here AirPods को हटा दिए. I think it's done. Okay.
So when are we going to start?
And we have called sir said he'll be joining in 2 minutes.
Okay.
Ma'am, Dr. Jelly Singh is having little issue in his connectivity. He will be like live in some 2 minutes, ma'am. Just 2 more minutes. Sorry for the inconvenience.
Dr. Sutapa, ma'am, can we start?
Yes, yes, yes. We are all ready. We were just waiting for a
Sir is having some difficulty in joining.
So then we'll start then. Maybe he
Yes,
can.
ma'am. Is it okay?
As-
We'll start, and then when sir joins.
But then how will we know where if he has joined? Because so we can start. I also have a very brief presentation, just for 2 to 3 minutes. So meanwhile, if he is there, then I will introduce him.
Okay, ma'am. Can we start formally? Okay. A very good morning to all. It gives me immense pleasure to invite you all for the 65th Iphacon Plenary Session 6, Maternal and Child Health, time to complete the unfinished agenda. It's my honor to introduce our chairperson, Dr. Stutapa. Madam is Director of Indian Institute of Health Management Research. Madam has got vast experience as a public health specialist, actively engaged in research and teaching at Indian Institute of Public Health Delhi, Public Health Foundation of India. Madam has finished her undergraduate from Nil Ratan Sirkar Medical College, Calcutta, and post-graduation from PGH Chandigarh. Madam has also finished diploma in MCH and with very good academic credentials. Madam has received Kataria Memorial Gold Medal for being the best outgoing student of PGMI Chandigarh. Madam's vast experience in public health, particularly in implementation of projects that is relevant to national policies and programs. Madam has authored several research papers as a reviewer of many national and international journals, and she's an associate editor of BMC Pregnancy and Childbirth. Ma'am, it's very honorable to introduce you now. I hand over the session to you, ma'am.
Thank you and very good morning to all of you who are present here. It's my honor to be chairing this session, which is on MCH, time to complete the unfinished agenda. So just to set the stage, I'll take you through some numbers because as public health people, we understand that we are fond of numbers and data and things which substantiate, all programs. So I'll just take you through some of these numbers just to set the stage. Just Are you able to see my screen?
Yes,
The
ma'am.
PPT? Okay.
PPT is not yet open. You're only seeing your folder.
Is it there now?
No, ma'am, only folder we are able to see.
Just a second. Is it visible?
Now it's visible, ma'am.
Okay. So whenever we talk of the status of MCH or for that matter any program, generally the one thing which strikes our mind is the mortality indicators. And here we see the indicators, the impact indicators for MCH largely include under 5 mortality rate, infant mortality rate, neonatal mortality rate, and maternal mortality ratio. This is where we were in 2005. This is where we are as per the latest data of 2018. This is what we want to achieve by according to the National Health Policy targets, and these are our SDG goals. The first thing which strikes your mind is that for all the indicators we have improved considerably from 75 to 36, 58 to 32, so the jump is actually huge. But then we have not yet reached the target which have been laid at the country level or even at the international level as per the SDG goals. So when we have a more closer look at the data, suppose this is the under 5 mortality rate, what we find is that it's not that the entire country is lagging behind. There are certain states which are actually faring much better than the national average, and there are even certain states which have actually achieved the targets. Yet there are some states which are, obviously above the national targets and obviously far from the targets that we aim to achieve. Similarly, when we talk about infant mortality rate, the same story emerges that there are many states in the countries which have actually achieved the target, yet there are some which are lagging behind. As far as neonatal mortality rate, the same story again goes on. For maternal mortality ratio, again we are at the same level. There we have improved, but there are many states which are lagging behind. But now I think the time has come when we have to look beyond mortality rates or deaths, and for this basic reason we have organized this session where we would want to tell you that it's not only the mortality indicators which are important, but it's time that we look beyond mortality and also look into morbidity and quality of life. But there are certain areas or themes which are very much cross-cutting in nature. For example, gender, nutrition, environment, and urban health. These are the areas which are cross-cutting in nature, which impacts not only MCH but in fact all other programs and health as a whole. So we also have a session to see how innovative approaches have been designed to address these problems. And that is why this session is very pertinent and important, which is MCH, Time to Complete the Unfinished Agenda. We have a team of eminent panelists who have done extensive work in this field of MCH on various domains, as we will hear from them. And we also have our co-chairperson, I think, who is yet to join us, but we will start with the session. The first speaker for this session is Dr. Rajesh Khanna. So I'll just share his screen, his PPT, and meanwhile I'll keep introducing him. Dr. Rajesh Khanna currently is the Deputy Director, Health and Nutrition of Save the Children India. He is a medical doctor trained in pediatrics and public health with more than 2 decades of postgraduate experience as a clinician, researcher, program manager, team leader, and policy advisor in the field of MCH and nutrition. He has worked with government and civil society at the national level in India and contributed significantly to the community processes that are instrumental for improvement in health. Evidence generation through information management system, systematic reviews, and expert consensus for development of evidence-informed policies and strategies being his primary area of interest, he has developed keen interest to bridge the gap between research policy and programs using implementation research, policy analysis, innovative technology, to name a few. He has contributed richly towards a number of research publications, key policy documents and guidelines of Government of India, NICE and WHO. Dr. Khanna is a member of the Pediatric and Neonatal Professional Organizations of India and a sitting member of key child health advisory groups of Government of India. Presently, he is providing technical leadership to health and nutrition portfolio of Save the Children India. He is a member of the senior management and program leadership team in India and a member of Global Technical Leadership Group. So over to you, Dr. Rajesh. Are you able to see the slides?
Yeah, thank you. Thank you so much, Dr. Sutapa, for such an eloquent, start. And first of all, a very good morning to all of you. And I would like to thank the organizers of Indian Public Health Association for bringing this very important topic of it and for inviting us to it. Next slide, please. Yeah. So I know, when we are talking of nutrition and gender, so I've been given 10 times and I'll try my best to stick to it. But the challenge has been that it's such an intricate topic that I don't feel we can do justice to it, but I'll try to cover on the main topics. So my outline will be starting from the global India burden, then what is the relationship that we see between MCH nutrition, and I'm not going to bore you with all the frameworks, but I'm just going to show you some graphs and pictorial presentations where you can see how it is being impacted. One case study where probably all three of them are being taken care of in a single manner, and then some recommendations and the way forward. Next slide, please. Sutapa, can I have the next slide, please? Yeah. Thank you. So, I think for maternal under 5 and neonatal deaths, yes, we seen that probably a lot of progress has been made by India, and our rate of reduction has been much better as compared to the global level. But if you see in terms of the numbers and the percentage share, and especially the lower half, which are all nutrition related indicators, you see that our progress, that we are contributing much significantly higher as compared to the mortality burden, whether it's related to maternal undernutrition or indicators of child undernutrition. Next slide, please. These are probably some causes which everybody would be knowing. But just to let you know that if you look into the maternal causes, PPH, anemia, they are front running in our country. Similarly, for under 5 deaths, this has been taken from 2015. But even if you take the latest data that has come from the Lancet 2021, you will find that preterm births contribute one of the biggest cause for under 5 deaths. And then you have those underlying causes of pneumonia and diarrhea, which are the low hanging fruits, and which my fellow friend Praveen will be covering just after this. So these are the things where if a child is malnourished, then the risk of dying increases between 8 to 11 times in terms of diarrhea and pneumonia. Next, please. Now, if you look into the risk factors, now this is an interesting thing if you look closely into it. Nearly 70% of under 5 deaths, which has come, which we have in the Lancet 2020, this has been a subnational analysis which has been done, and where you see by the India Disease Burden Group, they found that 70% of these deaths, malnutrition, maternal and child undernutrition is the contributing cause. And rest 22% is unsafe water and sanitation and air pollution. And this is again, which Dr. Praveen from UNICEF will be covering up. Next slide, please. So we all know that nutrition is going to be a major factor if we have to increase the rate of decrease in the under 5 newborn or maternal deaths. And even I would say adolescent deaths, because it's an intergenerational effect. Now, interestingly, 2021 also showed for the first time we had a subnational estimates of district-wise distribution of under 5 deaths. And this graph, if you see, I'll just try to explain it in very simple words, that, they divided the various districts into districts which have high under 5 mortality rate and which have low under 5 mortality rate. And then further, they looked into the pattern of rate of reduction over the past 17 years. Now here, The red, orange ones are the ones which have very high under 5 mortality rate, and the annual rate of reduction is slow. It means that these are the ones which are the high burden ones. Next, please. Similar analysis was also done for stunting. Now, look into it. It's again high stunting and low average annual rate of reduction. If you look into the distribution, the red, orange, and probably your mustard and the yellow ones, they're quite similar, at least in some of the parts where you can see is Uttar Pradesh, Bihar, Jharkhand, Madhya Pradesh, some parts, Odisha. So this is just helping us to further see that now instead of the state level, we also know at the district levels which are the districts which are contributing to the high level. And also shows us that yes, there is a very close relationship between mortality and stunting, wasting, and different impact indicators for undernutrition. Next slide, please. Now, effect of gender, gender is a thing which acts on every aspect of our life. So I'm just trying to cover two aspects through which gender is impacting maternal child health and nutrition. Let's look into the NFHS4 data where we have seen the proportion of males and females children being taken for accessing health services in different conditions. And I'm sorry, I don't have the p-values, but all of them are statistically significant because probably the sample size is quite low. Next slide. Now, even if you look into the excess of nutrition, now this is an interesting study that we did in Banswara district, where we found that maybe for breastfeeding, we don't have any problems, probably the excess is similar, but when it goes to dietary, complementary feeding practices, so dietary diversity and adequate diet, significantly higher proportion of boys are given preference for these things. And again, very statistically significant. This is an upcoming paper in BMC Nutrition. Next slide, please. So these are not only the two things. For gender to take place and have an impact on maternal child health nutrition, and it is taking place in our everyday life, there are different frameworks and pathways through which it brings, whether it's related to decision making, whether it's related to your socio-cultural practices, access to different resources. Everywhere gender is playing a significant role. And probably just to know that India is probably one of the only countries where the infectious diseases mortality is higher in girl children as compared to the boys. So coming to a case study where you can see all these three factors being impacted. Before I start the story of Jivika, in Bihar, CARE has been working through GATE support, and they have done a pilot work through Ananya project. Now, this was a project under which a small component was done to establish self-help groups. That was Parivartan at that point of time. Next slide, please. Then in 2014, they decided that, yes, community engagement through self-help groups seems to be a very nice mechanism of going forward. And they integrated all their successful learnings under the self-help groups which have been formed under NRLM at that point of time, or the State Rural Livelihood Mission. In 2014, Jivika was formed. And at this point of time, more than 1 million self-help groups, which is covering more than 54% of Bihar's rural population is being covered. Now, they started developing modules, which they started gradually integrating health and nutrition topics into those self-help groups mechanism using a modular fashion. Next slide, please. So if you look into this, so what they did was they realized that probably a major impact is going to come through changing the behavior. Just to tell you one important thing at this point of time, and this is something that we have realized over a period of time, for maternal child health, a lot of interventions can be one-time, like you have to give vitamin K, skin to skin contact, for maybe that has to be continued. But for especially nutrition related practices, you need to have consistent messaging over a long period of time, because these are behaviors which are quite difficult to change as compared to a simple intervention. So they developed a behavioral change module. They started in a phased manner, and then they've covered all the different platforms: home, village, organization, and at the community level. Next slide, please. Let's look into this. This was the first module that they started, which was focused on institutional delivery and essential newborn care. And they found that after 2 years of intervention, they found that in the intervention areas, the improvement was much higher as compared to the control areas. Next slide, please. Now, when you look into this slide, this is an interesting, because there already institutional deliveries were being promoted through the government health sector. But feeding practices which have been lagging behind a great deal in our country. Here, what they found was that compared to the control area, the dietary diversity and acceptable diet increased by nearly 1.5 to 2 times. And they adjusted it. It was quite a big sample size of 16,000, and this was being done at scale in 101 blocks. They found that minimum dietary diversity, there was a significant higher proportion, nearly 1.9 times higher children in the age group of 9 to 11 months were receiving dietary diversity in the intervention area. And for acceptable diet, nearly 2 times. And just to let you know, friends, that in our country, according to NFHS 4, the proportion of children who have access to acceptable diet or the adequate diet is less than 1 in 10. It's just 9.6%. Next slide, please. Next slide, please. So my recommendations are, this is something that I'm going to state, but this is apart from what we already know. First of all, here when the MCH cycle starts, the first 1,000-day period we start, already there is an equity gap present at that point of time, and that equity gap gradually increases over a period of time. And the best chances to reduce that equity gap is the first 1,000 days. The latest data is also showing that the level of stunting and wasting is highest in the first 3 to 6 months of life. So normally what we start doing is we identify children at SAM and wasting children after that, and our interventions usually start. But by that time, I think half of the battle is already lost. So we have to take this intergenerational loop into consideration. Next slide, please. Second, we know poverty is a huge problem in our country, and that is an underlying determinant for nearly all the problems. But it's very important, and we have a number of social protection livelihood schemes, but how many people are able to access it? And how does it impact nutrition and health services? Health services, we know, out-of-pocket expenditure when we don't have that. But for next slide, but for food, if we look into it, another interesting study that we find that people who are in the poorest quintile, they spend nearly 60% of their income for accessing food. And I'm not talking of nutritious food. I'm talking of energy-rich food, or maybe just macronutrient food, as compared to the richest quintile, where nearly 1/3 of the amount is spent. This study was done in a tribal district of Jharkhand, so you can well understand what will be the dynamics. So it's very important that unless you improve the scope of social protection and livelihood scheme so that the household income increases, only then there will be an improved access to health services and to nutritious food. Next slide, please. Third, I think the importance of women's role and empowerment has been we are not being taken aggressive action on it, because again, it is something which is inherent in us. It has been biases that have been going on, prejudice that has been going on in the society for such a long time. This needs to change, and it's not going to be an easy task, but I think that is going to be a critical factor if we have to reduce deaths in our country for maternal child health and also improve the nutrition. And overall, I would say for an overall improvement in the society. Next, the latest data that has shown shows that 90%, this was a very interesting study that was done where they compared the improvement in MCH indicators and nutritional indicators compared to the improving status of women. And they found that nearly 90% of nutritional status and 50% of reduction in the deaths could be attributed to improvement in the status of women in the society. Next slide, please. At this point of time, we have excellent platforms. We have Poshan Mission, we have Anemia Mukt Bharat, Poshan Mission 2 is now coming, but unfortunately, various implementation challenges are there, and I'm not going to go into the details. More importantly is we need to focus on improving the coverage, continuity, ensuring the continuum of care through that, intensity of the interventions, going deep to it, reaching out to the most marginalized sections of the society, and the quality of interventions. Next slide, please. And yes, the community engagement. I think till this point, we have been engaging with the community as they are the beneficiary, but we don't treat them as equal partners. Unless we understand what do they want, we bring them to co-develop interventions, especially when you're talking of a behavioral change, care seeking, and to create mechanism of accountability, we will not reach what we are planning to do. Thank you so much.
Thank you, Dr. Rajesh, for a wonderful presentation to enlighten us on how gender and nutrition impacts not maternal child health indicators in particular, and for taking us through the important case study from Bihar, which is Jivika. So our next speaker is Dr. Praveen from UNICEF. Dr. Praveen is a health specialist currently working with UNICEF. He has an experience of working with WHO for 2 years, DFID for 1 year, with Nutrition International for 4 years, and with UNICEF for a total of 14 years. He has worked extensively on international and national emergency responses, including COVID-19, Rohingya refugees, tsunami, floods, measles, and cholera outbreaks. He also has contributed a lot to conceptualizing and supporting the national diarrhea and pneumonia control campaigns, the revision of mother and child protection card, and also piloting of ED syringes. He has authored a handbook of multi-sectoral coordination for emergency response in India, and also has published 2 research articles in European Journal of Nutrition and Safety. So over to you, Dr. Praveen.
Thank you so much. Thank you so much, Dr. Suttappa, and good afternoon, friends. As you know, that India contributes to around 18% of the global total population. However, when it comes to the childhood pneumonia deaths, the contribution is 21%. And when it comes to the contribution of childhood diarrhea deaths, then it is 19%, which is much above the global total population contribution of India. Next. In India, a little less than 1 million deaths happen in under 5, and 25% of these deaths are due to pneumonia and diarrhea. The major contribution is due to the neonatal mortalities, that's from 0 to 28 days. However, the second major contribution is from childhood pneumonia, and then the third major contribution is due to diarrhea. Now, if you look at these 2 columns, first is your childhood pneumonia, and then the second is childhood diarrhea. look at the morbidity. Around 30 million episodes of childhood ARI or pneumonia happen in the country every year. 8 times to that of episodes happen in children of diarrhea. Now, when you look at the mortality, then the mortality commensurate to the episodes is more in pneumonia. That's 140,000 deaths happen due to pneumonia in children, and a little lesser, that's around 1 lakh deaths happen due to diarrhea. Now, where do these deaths happen? Majority at homes, 75% for both. And if you look at the rural and urban figures, then majority in the rural areas where our 75% of the population lies. So the proportion is more in rural areas. And in which communities do they happen? In the most socio-economic, marginalized communities that has poor water, sanitation, nutrition, etc., etc. All those deprivations. They also lack access to the healthcare facilities, and hence majority of these deaths happen at home. Next slide. Where has India progressed? There's a tremendous progress, no doubt, of decrease in mortality. Currently, the childhood pneumonia mortality is 5.7 per 1,000 live births, and for diarrhea it is 4.2 per 1,000 live births. Now the target of the national health policy is that it has to be less than 3 and less than 1 for pneumonia and diarrhea respectively. Now we have come down to this level, which is shown 5.7 and 4.2. Majority of it is due to a good, as you must have noticed, due to a good health system strengthening approach, though it may not be the best, but certainly it has improved. But then the further decline seems to be challenging, and I'll come to that why. Next slide, please. Now, where do these deaths happen? Majority. As Dr. Suttappa in her opening remarks has said, that there's a clear-cut stratification. And here you see for both pneumonia and diarrhea, majority of this happen in the northeastern states, and then the second one is in the central part of India, and then the eastern part of India. After that, it is the northern part. And fairly better is our southern part of India, where the mortality rates in children for pneumonia and diarrhea are very less. Next. Majority of these deaths, that the 60% of deaths due to childhood pneumonia are due to the bacterial causes. Though the morbidity, majority of it is due to the viral causes, but the deaths majority are due to the bacterial cause. Now for diarrhea that's 30% of it are only due to the bacterial causes. That's your cholera, Campylobacter, E. coli, Salmonella, Shigella, etc., etc. Next, and then the next majority is the rotavirus, which is 20%. Next. The climate dynamics are associated with the differential seasonal patterns for pneumonia. If you look at the India maps, there's a clear cut, and these months which are denoted are the peaks of mortality due to childhood pneumonia. Majority of that are during the winter months. That it starts from November, which is in the tropical savanna region, and then it peaks for January in the non-semi-arid and in the humid subtropical regions, and also then there is another peak which is considered as a non-significant peak statistically which happens in July for pneumonia. Now such geographical differentiations are not found in diarrhea. Diarrhea, the curve is fairly good, is fairly standard for across the states. The peak of diarrhea usually happens in July, and then there's another peak which we call as a rotavirus peak, which happens in January. So when we know that what is the geographical distribution, we know what is the seasonal pattern, and accordingly we need to devise our country strategy. Next. Next. Next, please. Yeah. So what are the approaches? The approaches are protect, prevent, and treat. That is the PPT approach. The protect are all the nutrition interventions which my friend Dr. Rajesh Khanna had already spoken about. I'll just touch a bit, which is the exclusive breastfeeding for 6 months. In India, as per the NFHS 4, it is 55%, but the complementary feeding has again reduced, which is 6%, which is as Dr. Rajesh said, around 9.6%. So the protect is all your nutrition interventions. The prevent is more on the environment, sanitation, safe drinking water, hand washing, etc., etc. I'll come on that in detail in next few slides. But also the prevent is also the immunization. Immunization, for example, the hip vaccine, your pentavalent vaccine, measles, etc., etc. And then the treatment part. Treatment of, if at all there is a case of pneumonia, diarrhea, you need to treat. For diarrhea, ORS and zinc, and for pneumonia, you need to give certain antibiotics, start on oxygen. Now, this framework which I'm talking about is from the Global Action Plan for Pneumonia and Diarrhea, which is adopted as it is by India as India Action Plan for Pneumonia and Diarrhea, which is known as IAPPD. I'll come to one to this. If you look at the ORS coverage, it has doubled in a decade. It is now 51%. Zinc coverage increased from 0.26% to around 20%. So there's a tremendous improvement. But then there's much path to be still covered on these areas. Next. Now let's come to the come to the environmental sanitation. 1/3 of the India's rural population still lacks access to toilets and still practice open defecation. Now, this is as per the National Sample Survey round, which was published in 2018. On the left-hand side, you can see the classical F diagram, which contributes to the diarrheal disease transmission, the diarrheal infection transmission. But if you look on the right-hand side, I'll come to the program aspect. You look at this blue dots. The blue dots indicate the program coverage. That's the Swachh Bharat mission. Almost all the states, as per the program claim, has achieved 100% access to toilets. But the NSS survey, that's the National Sample Survey, it reveals that it is not so. For example, Uttar Pradesh says that it has reached 100% toilet access, but the NSS survey says that it's just a little above 50%. So there's still much to be done on this front as well. Next slide. Household air pollution. In India, about 1/3 of the total pollution is the household air pollution, and 2/3 is the outdoor air pollution. But even that 1/3 of the household air pollution, as per WHO, it says that half of the childhood pneumonia deaths is attributable to the particulate matters inhaled from the household air pollution due to combustion of the biomass fuels. Now, which are these biomass fuels? Many. I'll just give you a few examples. It's your firewood, it's your cow dung, it's your charcoal, etc., etc. So your household air pollution generates something which is known as a cocktail of pollution. Next slide. Yeah, we cannot forget the ambient or this outdoor air pollution. It increases. That's the PM 2.5 level increases in winters, and it is more so in the northern India. This is from the World Air Quality Report of 2020. Next slide, please. A map of 8th of November 2018, which is on the left side of the slide, indicates that the majority of this pollution on that particular day, which is a winter, is in Punjab, Haryana, Delhi, Western Uttar Pradesh, and then it slowly is also in northern India, that's your Uttar Pradesh, Chhattisgarh, Bihar, etc., Odisha. Now this is for the outer air pollution. When we look at at use of clean fuels for cooking, we have a complete data only for a decade ago of census 2011. Majority, that's less than 50% of the household using clean fuels for cooking, which is what we consider either as an electricity or an LPG, was lacking. Was lacking in the northern India, in the northeastern region, and in the central India. We have a data of NFHS 5 only for around 22 states and certain union territories. And here also you can see that the challenge continues for the northeastern states even after a decade. Next. UNICEF had conducted a study in these states where you can see on the left side of the slide on the map in 2017. And what was astonishing was that in the samples in which we did the study, each and every family had said that there is no linkage between the household air pollution and acute respiratory tract infection or pneumonia. On the contrary, what they said is that when the child is sick, has cough, fever, difficulty breathing, they on the contrary take the child to give the child extra warm to the chulha, and which they considered as a treatment which is helpful for pneumonia. So this is the level of awareness, this is the level of knowledge which is there in rural India. Next. What are the gaps present? Now I have covered environmental factors and only few of them for diarrhea and for pneumonia. What is still remaining is that there is lack of understanding of the environmental factors. Still, I'll say it's not only within the health sector, but also outside the health sector. Action on these areas, it does not lies with the health ministry. It lies with the ministries which are non-health ministries. However, we have also seen that some of them do not heed to the scientific evidence, and always there's a challenge of some intersectoral activities, and these activities are usually not a priority. And if at all they have to do certain actions, then they are slow and episodic, as you can see, which will happen again during these winter times for northern India when the pollution starts increasing. So it's all an episodic action. The interstate coordination is very slow. You will have seen during the air pollution, there are some pollution generating states, there are some pollution imbibing states. So there's lack of coordination between them. The LPG has been delivered to a majority of families in rural areas through the Ujjwala scheme. But after that, there's a cost factor because then the family has to purchase the LPG gas for cooking. So that's a cost factor. And also, there's inadequate distribution of channels in rural areas. Does every block or every taluka has at least one distributor for LPG? That's a question mark. Public pressure is inadequate, and there's a very slow adoption of less polluting or clean technologies unless there's a push from the government either for a cleaner fuel, or there's a push from the judiciary. Next. How can we as a public health community address those gaps, and what's the way forward? There's already a division which is a newly created division in the Ministry of Health, which is known as the Environmental Health Division. We need to strengthen that. The Environmental Health Division needs to advocate more and more. And we as an experts and also from the civil society organization, we need to write something in media. We need to be in the media. We need to create more awareness. I was also intrigued by this hand washing day, which falls on 15th of October. Now, I don't know why it falls on 15th of October, whereas the diarrhea peak in India happens in June, in June, July, and the mortality is more in July. Can't that date be advanced? The solarization of the health facilities is within our hands, within our health sectors. Can we slowly move to a cleaner energy? Can we collaborate with the private sector for educating, piloting, demonstrating some clean technologies? And we as intellectuals, I think we need to monitor the India National Clean Air Program, which is from the Ministry of Environment and Forest, and also the Swachh Bharat Abhiyan, because I think if these two programs get a push from us intellectuals, I think it will contribute immensely to the reduction of pollution, and also will lead to a tremendous boost in toilet coverage. And research, I will not go more into that, but then that is an area which I think we as public health experts we need to do. On the right hand side, you can see a SARS logo. Now, SARS is a campaign which we have devised with Save the Children, UNICEF, and which the Ministry of Health and Family Welfare is leading and implementing. So this is a one which happens in the winter area, in the winter months. This is the one which is a campaign, which is a health system strengthening campaign, which is a training of doctors, nurses, paramedics, etc., on managing pneumonia, and also for creating awareness. And this is integrated intensified diarrhea control fortnight, which is also during the peak of diarrhea. So I'll just point these two campaigns which have been devised for tackling those peaks. Thank you so much.
Thank you, Dr. Praveen, for a very lucid presentation to inform the audience about how environmental health has been and will continue to play an important role for morbidity related to pneumonia and diarrhea. So now I invite our next speaker, Dr. Anuradha. Dr. Anuradha Jain is a senior advisor, health system strengthening, currently working with USAID. She is a clinician with formal training in public health. She has been a public health practitioner for the last 15 years and has served in various prestigious national and international organizations. For the last 7 years, she has been United States Agency for International Development, which is USAID. She has been providing strategic oversight to USAID's largest health system strengthening portfolio and USAID's COVID-19 pandemic response support for India, which is over $200 million. Dr. Jain has contributed to conceptualization and operationalization of some of the national flagship programs such as Rashtriya Bal Swasthya Karyakram, Janani Suraksha Swasthya Karyakram, India's Newborn Action Plan, and has contributed to the background papers for HLEG and health section of the 12th five-year plan of the country. So over to you, Dr. Anuradha.
Thank you so much, Sutapa. And I think the previous two speakers, I'm grateful to them for making my work far more easier. So Sutapa, can we have the third slide? Yes, thank you so much. Since this is a very august and esteemed gathering to whom I'm speaking, I really don't need to go through this slide in particular. But what I want to really stress is that one, the urban is a phenomena, and people who believe that the world should wait for the governments to designate area as urban or rural, maybe don't understand that they don't decide how people would want to live or how community wants to live. And hence the community itself decide what style of living and what type of living do they want, and accordingly they change their pattern of living. And hence urbanization can't be demarcated by the boundaries of a city or the boundaries of a township. It's a phenomena, and it happens very rapidly by urban areas expanding into peri-urban areas, and in engrossing the villages around them, and also the fact that the rural areas, the larger rural areas, they start changing their outlook into the whole urban, uh, urban outlook, and they start urbanizing in the way they build their houses. But the unfortunate part of this whole unorganized urban growth is that the planning somewhere suffers. And if we have good planned cities, the way those cities provide amenities to its dwellers, vis-a-vis when a city is very unplanned, and the way people suffer, and the impact of all this is on the human health. This is something we need to understand, and this is something we are going to deliberate as we move forward in the presentation. And there are problems that arise because of this fractured way of planning in the cities that we have, or the fractured way of governance that we have in the cities, that lead to a lot of problems with the people who are dwelling in these areas. So there is a very clear demarcation in which we need to view the urban. If you look at these statistics at a superficial level, whether it is NFHs, whether it is any other large scale data collection that happens, the law of averages come into action. And what we don't realize is that the urban is actually very iniquitous in its distribution of population. So there is either people who can afford all the amenities in the urban area, or there are people who are living in a very, very, in a situation where they can neither afford these amenities, and if they are also somehow scraping to afford some of these amenities, their priorities are different. And once there is a health shock that occurs in the family, it is such a big shock that they go into a catastrophic expenditure and suddenly fall into poverty. And that is the reason the indicators, if you divide in the urban areas into urban poor and urban non-poor, will significantly show you the difference in how the health status of people is, and how people are performing for that matter. I have here shown some of these statistics that may be of interest, because these are very startling statistics. So full immunization, the urban poor is almost 9 points falling behind the urban non-poor counterparts, and is actually in some sense equal to their rural counterparts. So there is a 40% lag in 40% children in the urban area, poor children in the urban area, who don't tend to get immunized. And there are various reasons for this to happen. We'll elaborate on the reasons, and we'll elaborate on some of the solutions that have been tested in the urban geographies. Similarly, the out-of-pocket expenditure that happens in the urban area. So everybody tend to think that urban areas have access to services. They do have access to services, but is it public services they have access to? Is it private sector they have access to? Or the fact of the matter is that the private sector is so fragmented, the whole sector is so heterogeneous, that it tends to lead to a huge out-of-pocket expenditure. And this is what is reflected in one of the slides present over here. The amount of out-of-pocket expenditure both for OPD and IPD that a poor person has to incur in urban areas. And similarly, the other indicators, whether it is ENC, whether it is PNC, The nutritional status and the pneumonia status have already been discussed by the previous two speakers. So maybe I don't even need to go into it, but the urban poor is performing worse than their rural counterpart, or is equal status to their rural counterparts. And one of the important reasons why this is happening is because there is a lot of migration that happens of the landless poor from the rural areas to the urban areas, who often reside in these crowded, poverty-stricken slum areas, especially in Tier 2 and Tier 3 cities, which are now becoming the sprawling slum aggregation for a lot of these migrants. So the next slide, please. Next slide, please. So here I would like to highlight, the role USAID has played in the last 21 years in the area of urban health. So we started talking about urban health as a group since 2001, and it took us almost 13 years to advocate to the policy makers that this country needs to focus on urban health separately beyond rural health, because rural India has structures well defined in terms of health delivery, whereas urban doesn't have structures which are well defined for urban delivery. And the way urban is structured, the hierarchical nature of health delivery system that we have in rural may not function very well, and we cannot negate the contributions of private sector in the urban areas, and hence they need to become integral part. 2013, the NUHM was announced in the country, and I think we can very proudly say that USAID work has contributed a lot to the launch of NUHM. Beyond NUHM, after 2013, we have been the technical assistant partners. Many programs Government of India has done in the urban areas, and we have also tested a lot of innovations in the urban area in the last 8 years after the launch of NUHM. I would elaborate on some of them, and I would elaborate on what the innovations have happened in the country after 2013. So can we go to the next slide? We have a few learnings that have come from some of our programs. And one of the learnings that we have from the USAID program is that whatever we plan, as the understanding is that last mile, whether it be an urban area or a rural area, always remains deprived of services because of very, very specific reasons. There are governance reasons, there are political reasons. We are not getting into some of those because a lot of people in this group know about those reasons of what happens. But the fact is that since there is no defined residence for some of these migrants that come to cities, they move from one place to the other. These are mobile populations that are there. There are hidden pockets within the sprawling, high-rise buildings. They get left out. They don't have those cards and those identification papers that help them access some of these schemes that they are entitled to, and hence they get left out from the service delivery mechanisms. And that's the reason some of the indicators are reflective of the fact that people do not get these services. There is a heterogeneous sector that I've already spoken about, which remains untapped for quite some reasons, again, political and governance reason. There is a network, there is an architectural network of services. It can't be hierarchical system, as I've already discussed. Then the cities are, experiencing triple burden of diseases, and the outcome in terms of COVID has shown us that if there is a comorbidity existing with some of these viral diseases like COVID, obese, diabetes, hypertension, what does it result into? How is the mortality of getting affected? And a lot has to do with the social determinants of the health, especially when it comes to health. And Dr. Rajesh has beautifully described Praveen has, shown us data on pollution. So social determinants become a very, very important area where there needs to be a lot of work done if urban complexities have to be addressed. Governance and convergence are the key to this particular problem, because it is such a complex area that different ministries have to come together to solve some of these problems. And we'll see in the next slide how it all boils down to impacting health. So we have listed out some of the systems gap here. We have listed out social determinants and governance gap. And lastly, the sum up of this very slide is that if these three sectors, which is social determinant, health systems, and governance, do not work in tandem and address some of the urban issues, the challenges that we are facing in urban health becomes very difficult to solve. Can we go on the next slide, please? So rather than focusing on problem, the organizers as well as the chair had asked me to speak more on what has been done, what are the upcoming solutions in the urban area, and hence I'm going to focus on those pieces of work because they are the important pillars on which we need to expand our services, because that's what we believe as USAID. We innovate, we accelerate, and then we provide TA and to reach the SDG goals in this country. And as a result, there are a few areas that I have picked up for today's deliberation. And the first point, is that of quality and the range of services that are being delivered, how some of the innovations has addressed some of these issues around quality and range of services. And the second would be the community, which is the most important pillar that needs to decide and take care of its own health, especially in a diverse society like urban, and come together as a homogeneous group to decide what they want. Is health their priority? And if it is, how do they advocate for it? Better health administration, which is part of the governance, health governance that we are going to, that we have just discussed, and the human resources for health and the decision-making tools and the decision-making data sets that we require. Can we go to the next slide? So some of the solutions that we have seen, and these are the solutions that I'm talking about, which are pre-COVID. Post-COVID, there has been a flurry of telemedicine that has happened in the country. But pre-COVID, these were some of the examples in urban area that we had seen functioning, and they had started, telemedicine. So there were multiple. I have shown two examples here, but there were multiple models that were being tested out for EUPHC and the EUPHC getting connected to the specialist services to increase both the services reaching the urban poor as well as connecting the urban poor to specialist care because of very particular two reasons. One, the specialists in the public sectors were overburdened. It was an overcrowded service mechanism that was present, and hence people needed to get the services at their own ease and at their own time. So these services were started, and the other problem was that specialist services are very costly in the private sector, and hence how do you reduce out-of-pocket expenditure? And as a result, these two models came up in the pre-COVID era, where there was a basic consultation that was provided through telemedicine to the slum population, and then people were connected to the specialist based on the need of that particular patient. There were good examples where the preliminary basic tests, the preliminary basic screening, all were being done through point of care devices, and the data was uploaded, the doctor could see it, and then the doctor could provide those consultation, patient who needed specialist services. The basic data was uploaded for the specialist to see, and then the specialist could provide those detailed guidance to the patient, advice on tests, advice on the drugs that were to be delivered, and as a result of it, patients were both saving money as well as their precious time, because these are daily wage laborers who cannot go, and they had access to some of these services at the time when they wanted to meet them. The only problem that some of these models saw was that wherever doctors were not available to provide these linkages with the specialist, and it was the paramedical staff who, as part of multitasking, was doing this job, they were not well versed with taking clinical history and all, and they were not being able to upload. But those are part and parcel of the processes that were being developed, and hence, some of these models have shown their effect during the COVID times and have evolved since then. Can we go to the next slide? Coming to the whole issue of diagnostics and the issue of service delivery in terms of diagnostics. So these are the two models that we are talking about. The model that was tried out in Telangana, which is the hub and spoke model, is a model where the government has established the hub at a central lab, which has state-of-art machinery that was brought in. The lab technician, microbiologists, pathologists were brought in large numbers. The spokes would gather all the samples from around the community and bring to this hub. The data would be generated, the test would be done, the data would be generated, and it would be straight away uploaded on the mobile through a server of the patient as well as the facility that was sending these lab tests. And as a result, most of the test result would directly go to the patient by evening. This kind of model actually saved quite a lot of problem in terms of both supply chain, reagent, and availability of the diagnostic services. Not only that, it actually brought down the cost of the service to 15 rupees per patient. And it is being claimed that if this model has more footfall that happens, the prices could be brought down to as less as 8 to 10 rupees. And the number of tests that are being provided are 65 plus in these laboratories. Can we go to the next slide? And why am I presenting some of these systems innovations rather than specifically presenting the MCH example? Is the very basic reason that the problems of maternal child health, family planning, adolescent, TB, and any other program for that matter remains the same, because human being remains the same. It is the systems that change, and hence the approach to these problems in rural and urban areas need to change. And from the first two examples that I have shown, a lot of pregnant women, a lot of children have actually benefited. We do not have a study at this point of time to show how these have brought changes, but there are anecdotal evidence in form of community voices that we have available that actually show that a lot of pregnant women, children, and old age people have benefited from some of these models that were shown earlier. This is another model of a primary health care where different states have tested out near community-based facilities, which are serving a population of average 7 to 14,000 in different states. And these have largely three items available with them, which is doctor, diagnostic, and drugs, which is the basic need. The criticism of some of these services are that they do not have community engagement, but actually if you go down and see in the community, these facilities are situated so in the center of the community that a lot of I can quote one of the examples from what we have seen in Basti Davakhana, that it is a beautiful example of intersectoral convergence. The municipal corporation has provided buildings for these services to be started. People own those buildings because these were shadi halls for people, and people come and clean them. They provide the basic protection to these facilities so nobody harms them. So actually these are owned by the community and community feels at home coming to some of these facilities. Can we go to the next slide, please?
Ma'am, if I can interrupt, ma'am, sorry, we are running short of time. If you could conclude, ma'am. So sorry to interrupt.
No problem, sir. So these are some of the other examples in the primary health that we have. Can we go to the next model, please? So these are some of the models from the HR vacancies. I would only elaborate on one where bidding of medical officers and specialists were done in Jharkhand, and the least form, pricing bid, whichever HR was giving was taken in account. Can we go to the next model? These are some pay for performance example from Odisha that people can go through, and maybe these slides would be circulated at some point of time. But this is another example from HRMIS where the systems were established for people to be trained, people to be monitored. Can we go to the next example? I would love to speak a line about the community. Next, please. This is an example of intersectoral convergence where municipal boundaries were taken in account. The divisions were brought together. There were divisions that happened in terms of areas, and people were allocated blocks and areas from different departments so that intersectoral convergence could be established and they can take care of each of these areas together. And this is a very good example of governance in Tamil Nadu, which had streamlined a lot of services. There were weak community structures. This is an example of how community can be strengthened, bringing another intersectoral convergence in the city where different programs can be piggybacked by the health program in community engagement to take advantage of them. Similarly, the training and the capacity building of the mass and how they are getting utilized into service delivery and service organization, and social determinants of health, community is taking part in it, and how community is itself responsible for some of the sanitation services. Can we go to the next model, please? So this is an example of 108 where GPS has been installed at the app point, and rather than wasting time, the ambulance can reach at the GPS location from where the call is being made, so that the precious time is saved and mortality decreases. Can we go to the next slide, please? Gujarat TECO model is well known. This reduces the faults in entry points of the data, and direct online entry is done by the health staff itself. And this has actually revolutionized the way data is coming in and data is available for information. So my last slide would be on the public health community and how it can address some of the gaps in the urban areas is on the 4 R's. One is that they can recognize the problem. Implementation research is something that the public health community and Department of Community Medicines can take up. We have seen a lot of small researches that happen through students in both the medical colleges and the nursing colleges, especially in the urban area. If the medical colleges can assign actually issue of interest, which can feed into policy to these students, and they can do some of these research, and organizations like UNICEF, USAID, WHO can use this data and help them document and feed them into policies. Then we can have real-time evidence that can be curated and information that these public health institute can help us, the public health community can help us come in both from the gray literature and from the white literature that is coming up, and that can feed into policy revisions that we are helping out governments with. There can be a process established. We are also trying to bring in different intersectoral institutions to form a resource center that can help some of these policy revision. we can help people, we can help engage communities through various different mechanisms to revive and revitalize the partnership and collaboration. And last but not the least, the communities can be empowered to regulate some of the work that is being done, some of the research that is being done, and some of the implementation that is happening in the field. So thank you, and thank you for giving me this opportunity to present.
Thank you, Dr. Anuradha, for a detailed presentation on what the problems of urban health are, and also to highlight the best practices, many of which were not known even to me for that matter. So I think it's a very insightful presentation. So we'll now go to the last speaker. Dr. Ashfaq from NIPI, Norway-India Partnership Initiative. Dr. Ashfaq Ahmed Bhatt has done Masters in Healthcare Management from University of Surrey, UK, and also Masters from Harvard School of Public Health. He has 22 years of working experience in public health and has worked in for many years at the subnational and national levels, and also within multilateral and bilateral agencies. Dr. Ashfaq has extensive experience in forging partnerships, consensus building, and outstanding leadership and coordination qualities, fostering integration and teamwork. He has also worked for more than 10 years in WHO as part of the Global Polio Eradication Initiative and strengthening its routine immunization systems. He currently leads the Norway-India Partnership Initiative, which is NIPI. NIPI provides technical support in maternal and newborn care to bring about a drastic reduction in preventable deaths at national level and in 5 states of India, which are Bihar, Jammu and Kashmir, Orissa, Madhya Pradesh, and Rajasthan. Over to you, sir, Dr. Ashfaq.
Thank you, Dr. Sutapa, and I'll take this opportunity of thanking the organizers for inviting me for this session. I'll be very brief. I think my predecessors have already kind of discussed into identification of problem statements, and that is the crux where I wish to move into. So just very quickly, a snapshot of what Norway-India Partnership Initiative is. I think it's a wonderful initiative between Government of India and Government of Norway. It provides catalytic, strategic, and technical support to the National Health Mission. The reason why I'm putting in here is because National Health Mission, this NIPI program or NIPI initiative is firmly embedded within the health systems. I think I have a hypothesis which I usually use in my presentation, says I would be a fierce advocate of disbanding projects and starting from let's have this idea about disbanding projects. Projects do work in a very small scale, and when it comes to the program mode, it fails. So how do you ensure the health system strengthening or the component to it? So I have a hypothesis, maybe I'll discuss this at some later point, but the point I wanted to make here is that providing technical support within the NHM. So we are working outside the government, but working within the government. So we have a very clear mandate of scaling up what has been kind of demonstrated through this partnership. Innovations has always been our prime area. How do you innovate and strengthen the innovation development capacity? I think time has come, as my previous colleagues, Dr. Rajesh, he was talking about Jivika, Dr. Praveen and Dr. Anuradha, they were also talking about innovations or leapfrogging approaches or innovations that can bend the curve. And then documentation. I don't want to go into the third objective, but innovations, and this is our work area in the 5 states, which Dr. Sutapa has already mentioned. Just wanted to highlight this innovations component we've been working since 2006 in this country, and Norway-India Partnership Initiative has brought in a lot of child health innovations and maternal health innovations into the forefront. The classical examples being HBNC, home-based postnatal care, demonstration of implementation of home-based implementation care. Then one of the biggest health programs that country is doing at this point of time, the home-based newborn care plus HBNC plus now has transitioned into HBYC, We have worked on establishment of SNCUs and ensuring discharge through SNCU Plus. Family-centered care, care of small and sick newborns, that has also been done. Emergency triage assessment and treatment, newborn care resource centers. We have been providing support of strategic support, we would say at this point of time, to RBSK program through establishment of the RBSK unit in the Ministry of Health and Family Welfare. And then coming to the maternal health side, pre-service nursing education, obviously strategic support, revitalization of postpartum IUCD that started in 2010 in one of the states or one of the districts in Rajasthan. Dakshata, we intrapartum, how do we strengthen intrapartum and postpartum care? We have demonstrated a model of birth companion through Yashoda, which has been successful, which has not been successful in some other states, and I'll go into that part. And one point of care diagnostics by the name of Swasthya Slate. So these are some of the innovations. So if you see the difference between the first slide and the second slide, we have been successful in most of the innovative approaches, but I have also highlighted emergency triage assessment and treatment and Swasthya Slate, where I see that how do you bend the curve of MCH, which the relevant topic or pertinent topic is. So how do you ensure alignment of countries' priorities, countries' problems, and do an innovative service delivery approach. It could be a demand generation approach, it could be a technology approach. But in some of the innovative approaches, we have succeeded. We have succeeded immensely in, say, for example, HbNc Plus, as Dr. Praveen and Dr. Rajesh was pointing out in terms of ensuring the, I would say that HBYC, the home-based care for infant program, is started from adequate diet. The VK Paul slide of 9% people, 9% only having children having adequate diet, and how do you ensure an innovative service delivery approach towards that process. And some of the innovations, say for example, ensuring intrapartum, strengthening of intrapartum care, say for example through Dakshata program, that has, how do you ensure care of small and the sick newborns, that has transitioned into family participatory care through the system. So the point I want to drive here is that if we understand, and that would be part of my presentation, the next slide as well, but some of the interventions we haven't succeeded. Say for example, we haven't been able to do the push that for emergency triage and treatment, which is one of the components of strengthening of pediatric care at this point of time, but we haven't been successful. And why we haven't been that successful, I think that warrants and trust. So how do we align as development partners the priorities to the states? So next, please. So as I was pointing it out, HbNc Plus, we had a well-defined problem statement. We were immunization. The rates have, there has been a change of 1% over a decade. IYCF practices, behavior change communication, very difficult to change. So how do you develop an innovative service delivery approach towards that mechanism in terms of structuring and using the infant care visitation as one of the most important components? How do you ensure breastfeeding? How do you ensure the immunization services and the full immunization complement is done? So doing an innovative service delivery, these interventions were working in the country. We had IYCF program, we had Anemia Mukt Bharat program and all those components, but how do you integrate? Because one of the biggest challenges that is being faced is once you develop an innovative approach, is how do you implement? There are implementation challenges. So how do you integrate into a service delivery approach? So a very simple approach in HbNc Plus was used. 3 months, breastfeeding falters. So how do you reinforce? So you get in an ASHA worker to reinforce the message. 6 months, complementary feeding starts, the breastfeeding starts, exclusive breastfeeding starts to decrease. So get in an ASHA worker to reinforce the message. And how do you ensure adequacy of diet? I think that is one of the components of the HbYC program that I am talking about, which transitioned into this component. How do you ensure ECD component? How do you ensure ECG messaging? How do you ensure adequate play and communication? I think that was the success. And if we define that, we had a well-defined problem statement, It was an extension of the HBNC Plus program, HBNC, because that was catering to the newborn period. Ownership, definitely on that part. There was a demand side need because we weren't taking enough care. The health systems were getting weakened on from 3 months of age. There was no contact with the health systems. Additional, we haven't used any additional since one of the components that NIPI has been successful. We haven't been using, and that is my hypothesis. Let us disband the project states. We can demonstrate, but let us always think about the programmatic program, that this is a program. HBNC Plus, if you see HBNC, newborn period, if you see it in a project mode, tremendous rates in decrease in maternal mortality. But once you go into a program mode, the whole system falters in the enormity of the challenge that we have to follow. And then we followed up with the robust evaluation systems. But if I talk about emergency triage assessment and treatment, I think one of the things that we also neglected at this point of time is identification of the problem statement. What Government of India and the state health societies are thinking about at this point of time in terms of emergency triage assessment and services, we do not want to take only pediatric care strengthening. We want to strengthen the emergency care services of a district hospital in all the services, be that pediatric care or the adult population. So that is where the problem statement was not well defined. We hadn't had inadequate mechanisms to monitor the progress, and there could have been a possibility of introducing technology at that point of time, but we did not do that part. And lackluster ownership at the facility level. Most of the what the states did, they shifted their HR to emergency triage, but OPD services were still getting affected. So there is a need for relook into those components. I may say that we have succeeded. We are still working on operationalization of emergency triage. But what about inpatient care and the outpatient care? I think that keeping in view the minimal staff we had at the district level. Next, please. So how did we achieve? How did we achieve what we achieved? I think very quickly going on this slide. So one of the things, so the key takeaway from me would be for this presentation would be, we need to establish, understand, and define the problem statement. We come up with solutions very quickly, but this is the crux. So we analyze the pain points in terms of policy, program implementation, and program performance through a demonstration, because that is, then we gather insights into the potential solution. We conceptualize. So if I'm talking about, say, for example, we are developing a decision support system for community health officers, and the problem statement is that this is a large cadre. They have a complex decision making. So you conceptualize, so you establish the problem statement, analyze the pain points, gather insights, conceptualize the innovative programming, demonstrate so that you get to understand, evaluate, bringing the necessary evidence, and then you advocate for scale up after a defined demonstration has happened. Next. And then implement at scale. So this is the model that we have been, and we have been following up the WHO health system strengthening model, leadership, using administrators from states, financing, PIP resources, information using the existing tools. We did not create new tools in HBYC program. We knew that IYCF program had already existing tools and job aids, so let's use them in the HBYC program. Human resources, we have to be mindful of that component. How do you leverage digital technology, and how do you focus on access with quality, including equity? Next, please. So if I sum it up, what is the NIPI wisdom for this component? We need to have, I think one of the components which Dr. Anuradha was also talking about is flexibility and acceptance of risk. Risk or failures, we have failed in some of the interventions. So if as policy level makers or public health implementers, I think one of the importance is that we need to have the necessary flexibility and acceptance of risk when we are talking about failure is definitely part of success. How do you find the right governance structure? So how do you embed your problem statement with the countries and the states' priorities? And the second part is the deep understanding of the problem statement. I think that is where I would request everybody to focus on understanding the problem statement. We do come up with innovative solutions. Say, for example, we are working on AI-enabled health solutions. but does that cater to the problem statement that the country faces? And that is a dilemma that we need to have. We need to have very strong, flexible monitoring and evaluation mechanisms, and then obviously the need for documentation and advocacy for these activities. And we have a necessary scale-up plan which is aligned with country priorities. So if I come back to Dr. Suthapa's, how do you accelerate? I think innovate, understand the problem statement, and be mindful of the factors that I have used as part of the NIPI learnings that we have. Thank you very much.
Thank you, Dr. Ashfaq, for bringing out such important lessons from NIPI, but I think it is equally applicable for any health programs that we as public health practitioners are engaged in. So that brings an end to this important session on MCH. I think we can take few questions. I know time is very short. Only one question is there, so it is, how do we stop the fudging of program data to meet political ends? Professionals are bending backwards to project fudged data for their own needs. So this is not directed at any speaker, but if anybody wants to respond to this question, it's an important point though. So please feel free to respond, and with that we will close this session. The question I'll repeat is, how do we stop the fudging of program data to meet political ends? Anybody wants to comment on this?
Now, Dr. Suthapa, I think that was highlighted by Dr. Praveen in terms of, and Rajesh, in terms of accountable mechanisms. I think accountability and moving from service side, I would add up here from service side to the service seeker. I think that's what Dr. Rajesh also pointed out. Moving from service seekers, I think that is the critical. If you hand over the baton to them, they start demanding your services. I think CoWIN app has been one of the learnings that I would say at this point of time, that people are demanding services, and then you see that the slots are not available, etc., and all those things. So handing it over to the service seekers, I think that would be a critical component.
So thank you, everyone. You want to say something, Dr. Anuradha?
No, just one thing. I think in governance, transparency is a key. So if the data is transparent, openly available for people to view, there is an institutional mechanism that is available which vets before such such evaluations or such reports, which is comprising of various sectors of society, whether it is community, academicians, which is something which UK does, and all of us have been propagating in this country for so long. And I think Rajesh would be the biggest advocate of a nice light body in this country. If those two things are there, I think a lot of fudging can be prevented. I would not say it will stop, because data is something whoever wants to use in the way they can, they would. But these are the two ways.
Thank you, Dr. Anuradha, Dr. Ashfaq, Dr. Praveen, Dr. Rajesh, for your very important and interesting presentations. And at the end, on behalf of all the panelists, I would also extend my thanks to the organizers of the 65th Annual National Conference of IPHA. Thank you so much, and over to you, Dr. Satanshu.
Thank you, Dr. Suthapa. Can you hear me?
Yes, please.
Yes, thank you. That session was so interesting. Though there was a little time was a constraint, but we wanted to have continue that session. It's so interesting, and always I know the passion for MCH and other things that you have from our postgraduate days. So I think it's on behalf of the organizers, it is our privilege and it's our duty to also thank all the panel speakers here, particularly Dr. Rajesh, Dr. Praveen, Dr. Anuradha, and Dr. Ashfaq, and also the chairpersons, Dr. Suthapa. Dr. Jile Singh could not join us. But before we close this session, there is a small thing that we'd like to do with there is a book that is going to be released now. Just I'm sharing the screen. Can you see this? So we take great pride in releasing this book on this 65th Iphacon platform. This book is titled Gender Before Birth in India, Role of Indigenous and Traditional Medicines. This was written by Dr. Suttappa Bandyopadhyay and Yogi. When I joined community medicine in PGI, I still remember in Narayangarh we were going in the rickshaw and trying to find out how indigenous medicines were practiced, how people have their preference for sun preference and other things. So it is almost now 18 to 19 years,
19 years.
20 years, okay. So still the work is continuing, and that's how the research should continue. The passion for one particular issue that should be taken to the logical conclusion. I think this is a wonderful initiative, and thank you so much, Dr. Suttappa, for allowing us to release this book in this platform. Regarding a little bit about this book, the book focuses on the role of indigenous, just a minute, system of medicine or traditional medicines in gender selection in India. Issues such as harmful effects of traditional practices on the health of women and fetus during early pregnancy are explored in this book. We'll allow Dr. Suttappa to tell about this book a little bit, but about the author, Dr. Suttappa needs no introduction. Would you like to say a few words, Dr. Suttappa, about this book for our audience, for the benefit? Yeah. Over to you.
Yeah, thank you so much, Sitanshu and the entire team for releasing this book. This book is basically an effort to jot down the journey which I had gone through right from the time we got to know about this practice, which was in 2002, 22nd October to be very, very precise. And since that time till date, what all we have undertaken to make sure that this practice goes through rigorous process of research, and finally the research finding should be, it should become a part of the program implementation, or at least it should be able to influence policy. With that hypothesis, we had undertaken this task, and I must say that this has not been a very simple journey. But this has taught me the real public health, I would say. This has taught me that public health is not only about health, but we need to be, whatever we talk about intersectoral coordination, all those things actually I could practice while I was doing this work. And many thanks to all those who have supported me in this endeavor. Thank you.
Thank you. So we know Dr. Suttappa, her journey will be always full of challenges, and she is not a person who is going to be bogged down by those problems and the challenges. So the journey is never going to be easy, that as we know. So with that, we conclude. Thank you so much. It was a lovely panel. I'm so sorry for reducing the time in between, but as the organizer, we have to stick to time. So please excuse me for that particular thing. With that, we close this session. Thank you so much for joining us.
Thank you so much, all of you.
Thank you.
Thank you.
Thank you, ma'am. Thank you, sir.
Time,
Okay, good afternoon, everyone. We are dot at 2 o'clock and we are going to start our 10th plenary of the 65th Iphacon 2021. The title of today's plenary is Reaching the Unreached, Ensuring Adequate Nutrition to All Vulnerable During COVID-19. We have two distinguished chairpersons for this, Dr. Najam Khalik and Dr. Vikas Bhatia. Dr. Vikas Bhatia will be joining in another 2 to 3 minutes. He's the executive director of AIIMS Bibinagar. So he's held up in some meetings and he will join as soon as possible. So it gives me immense pleasure to introduce Dr. Najam Khalik, professor of Department of Community Medicine, Jain Medical College, AMU. So we have another three distinguished speakers. I request Dr. Najam Khalik sir to please introduce them. But before we hand over the session to sir, let me tell a little bit about the genesis of this particular plenary. So when we talked about this plenary with Dr. Sarika, actually Dr. Sarika is the person who motivated us to do this plenary on nutrition, because IPHA is a platform where almost 8,000 members with we have 1,500 people registered. So nutrition should be considered as a very important component in public health teaching. And that was the goal with which we discussed this idea. And then we started talking about how to rope in different experts for this particular session. So with so Dr. Sarika actually took a lot of pain to connect all of us. So it was really so nice of you. Dr. Sarika, if you can unmute your video, please.
Thanks, Sitanshu. Though the credit, you're giving me the credit is actually yours. But thank you so much for the kind words.
Yeah, it was so nice. And Rashmi also, please, if you could switch on your video. And I'll also request Dr. Najam Khalik, please to switch on his video so that at least we can take a photo and we'll start on time. Sir is logged in, but I'm not able to see. Dr. Najam, can you hear us? All right. So probably there is some internet or connectivity issue there. So let me start introducing the first speaker. Then we'll go on, and the others may join during the course of the time. So can I have the bio of Dr. Rashmi, please? Yeah, it's a great pleasure to introduce Dr. Rashmi to this forum. We have not met personally, but probably nowadays with the COVID scenario, this is the new normal, I guess. We'll meet everyone virtually and then become friends and then start working together in certain areas. So thank you, Rashmi, for accepting our invitation. And Dr. Rashmi is a research fellow in IFPRI's Poverty, Health and Nutrition Division. She has 10 years of experience in conducting implementation research. She has got multiple awards and fellowships to her credit. But to name a few, she conducts studies focused on system strengthening to improve coverage of health and nutrition interventions for women and children. She leads the stream of work on subnational success case stories on improving child nutrition in India under Poshan partnership and opportunity. We know Poshan, what is it? So Poshan Abhiyan. She has a PhD in health promotion, education and behavior from University of South Carolina, the United States of America. So without any further delay, so over to you, Dr. Rashmi.
Thank you, Sitanshu. Should I just go ahead and share my screen and play, or?
Yeah, we can do that. Or you want us to play that? Whatever is suitable to you, we can do that.
Okay, I'm here experiencing some technical difficulties. I can go ahead and start, and if there is something you always have.
Yeah, we'll fall back on that.
Okay.
That's good.
Yeah. Thank you so much, and thank you for your kind introduction. And it's a privilege to be part of this conference and to be presenting here. And thank you to Sharika and organizers for inviting me to be part of this effort. I'm going to, and just to clarify, Poshan is a program that under IFPRI that we can work on. It's not related to Poshan Abhiyan.
Oh, I'm so sorry for that. I'm so sorry.
And our Poshan started in 2011. It predates Poshan Abhiyan. I'm just going to go ahead and start share this screen. I hope you can see it.
Yes, we see it.
Yes, okay, great. So this work that I'm going to present is based on contributions from several colleagues. We had a consortium of researchers from 6 organizations, and including the IFPRI team. And I present these findings based on behalf of all of them. And it's really great to be here. Thanks. So just to set the context, nutrition has seen unprecedented attention in the past decade. And this has happened because it got into the Sustainable Development Goals onto that agenda, as well as back in 2011, nutrition has been set as a target under the World Health Assembly targets, which to be achieved by 2025. These ambitious targets include reductions in stunting, anemia, low birth weight, in the reductions in child overweight and wasting, and improvements in exclusive breastfeeding. And these have been set to achieve by 2025, and now they have been extended to 2030. Of course, these global targets also have nutrition-related non-communicable disease targets as well, such as the overweight, high blood pressure, and high sugar levels. But for now, for this particular talk, I'll focus on the nutrition-related targets, and particularly on stunting. So as there has been focus on nutrition, targets have been set, countries have became signatories to these targets, and they're monitoring the progress. The questions have been how to achieve these reductions. And just thinking about stunting again, the UNICEF conceptual framework, which you see here on the screen on the left, this gives us a great framework to think about how to improve child nutrition. There are several set of what we consider immediate determinants that relate to food, health, and care, which have immediate effects on child nutrition. And then there are several underlying and basic determinants, which include women's status, sanitation, hygiene, food security, socioeconomic conditions, etc., which have implications on the immediate determinants of the food, health, and care. And together, these, sorry, I'm just going to get the point. Together, these determinants have an impact on the child nutrition and development. And there are different programs and interventions in place to improve to ensure that these determinants are in the right direction and help in improving nutrition. So what does this look like? This is a framework, but what does it look like in real life? About 8 years ago, two research entities have been conducting success case studies of positive outliers in about 11 countries and 4 Indian states, which included looking at where stunting reduction has been seen. So the effort has been to look at what does the evidence look like in these different geographies, and what led to changes in stunting reduction. And what together has been found across board is that improvements across multiple determinants, including socioeconomic status, maternal education, various maternal factors, and changes in health and nutrition interventions contributed to reductions in stunting in these various geographies. This particular graph is a picture indicates is the results is a depiction of results of changes of decomposition analysis, which shows contributions of various factors to reductions in stunting. And by looking at the color variability across these geographies, it shows that there is a combination of factors, and those combinations vary by geography. So there is no one size fits all, but across board, what is common is multi-sectoral solutions are imperative to address stunting. Now, if we dive a little bit deeper into the success case stories of India itself in the states of Chhattisgarh, Gujarat, Odisha, and Tamil Nadu, we find similar results. For example, maternal factors contributed between 15 to 30% reduction in changes in stunting. And this 15% in Chhattisgarh, in Gujarat, and about 17% in Odisha, and 30% in changes in Tamil Nadu. Similarly, household conditions and health and nutrition conditions contributed to stunting reduction. But there are certain common elements across board that facilitated these reductions. And what are those drivers of change? That's having a vision at the state level to achieve improvements in nutrition or maternal mortality or reductions in stunting, and creating an enabling environment within the state. And by that, I mean there's across board, what we have seen is leadership at the highest level at the state, and having champions and catalysts in the civil society organizations, development partners, among bureaucrats who ensure that programs were implemented to address the factors that have impact on stunting. So under the national program umbrella, state governments implemented several state-specific programs. So a confluence of factors came together to help address stunting in these states. And these are the changes that we have seen between 2006 and 2016, when that is to say between NFHS 3 and NFHS 4 data. So what does the stunting look like in 2019 in India currently, right? So if we move to that, in December 2020, fact sheets and later on reports were released for about 22 states, and union territories. And this is the most recent data, the National Family Health Survey data, the 5th round. And looking at changes in stunting prevalence among children under 5 between 2016 and 2019, what we find is in 7 states, stunting prevalence reduced in these 4 years. In about 11 states, 13 states, stunting prevalence either increased or remained stalled. The progress, there has been no progress. And among the states that have seen stunting reduction, Bihar stands out with, Bihar is one of the states that stands out with 5 percentage point change. Manipur and Sikkim are the other states where 6 percentage point reduction has been seen. Tripura is one of the states where, of the 13, where there has been the most increase in stunting, about 8 percentage point increase. While we see that in Bihar, we have seen there is a decline in stunting, if you look at the map here, the burden remains still high. 43% of children in Bihar are still stunted, and the number of children among all the states that currently we have information available on, Bihar continues to lead. So what this tells us is that while there have been reductions in stunting, we are still not there yet, and efforts have to continue to be focused on improving conditions. So how do they work? And we have talked about different factors that affect stunting. So now with the new NFHS 5 data available, how do the different determinants of stunting look like? So what we find is, in terms of the program coverage and immediate determinants, there have been improvements in the coverage of various health and nutrition interventions. Overall, more states have seen improvement than have seen decline. And this is a good place to be. However, to achieve further reductions in stunting, we need at least 90% or 100% coverage. And we are not there yet. So there is room for improvement. In terms of immediate determinants, such as infant and young child feeding practices, there is a mixed picture there. In early initiation of breastfeeding has worsened, and so did timely introduction of complementary feeding. There have been some improvements. Exclusive breastfeeding improved. Adequate diet levels have improved, which relates to complementary feeding, but the levels are still quite low, and there needs to be a substantial investment in improvements of infant and young child feeding practices. Now let's move to the maternal characteristics. Between 2016 and 2019, there have been improvements in women's nutrition from the perspective of there have been reductions in underweight, but anemia increased. So and if we think about the other maternal characteristics, improvements in other maternal characteristic domains, such as women's education and age of marriage, there have been improvements in these domains, but they have been quite small. So while there have been improvements, because they have been small, the overall levels are still low, and these remain a challenge. And focused efforts are needed to improve women's education, age of marriage, and of course the women's nutrition. So all these are still need substantial improvement. If we moving to the household conditions, there have been huge and consistent improvements in water and sanitation. Little is known about poverty and food insecurity, however, and we need to and the inequalities that are within the state. So we have a lot more to learn about in that domain before we think about solutions for that. Now, what we have seen, so what does all this mean? We have programs, we know what to do. So how to do, what is it that needs to get done? So for that 1,000-day families and families with adolescents, what is needed is that there are programs in the Indian programmatic framework, which include health interventions such as IFA supplementation, antenatal care, immunization. We have ICDS services, which include food supplements, counseling, screening. We have food security interventions. There are PDS, maternal benefits. There are livelihood programs such as NREGA, and then sanitation programs. And then there are midday meal programs. There are several social safety net programs. Now, what needs to happen is that all these programs converge on the 1,000-day households, forming a protected sector. So this has to happen, what we call it as effective convergence of all the services on those households. We are still trying to learn about how to make that happen because we have the programs, now they have to converge. Now, while we have been trying to figure out how to improve nutrition, we have gained some improvements in nutrition between 2006 and 2016. The efforts are continuing between 2016 and 2020. In between, COVID came, and that nobody had control over. Now, COVID-19 has impacts on malnutrition. We have to consider how it affects malnutrition in India. And these effects could be direct, which is directly because of the COVID infection itself, and depending on the severity of the infection, access to healthcare, and the financial and human resources that are available and redirected at the household level, at the community level, it has implications for health status and recovery from illness and the diet quality, which are the immediate determinants for the nutrition. And if we think about the indirect impacts, there have been measures to curtail the spread of the disease, which is lockdown and physical distancing. There have been changes to provision of services, changes to food supply, education. There have been changes to education programs. Schools have been shut down for a long time. And then there have been changes to social protection programs. All these have implications for incomes, wages, utilization of services, which eventually have implications for poverty, food security, women's status, wash, and then finally to the diet quality at the household level, what happens with child feeding. And then there are long-term implications. And all of this also can be looked at from the view of what these mean in the short term, medium term, and long term. And we have not even started to grapple about the long-term implications of missing or not having access to several of these services. So, I mean, for now, I'll be focusing on the coverage of health and nutrition interventions and food security. So when COVID started back in last year in 2020, a national lockdown was announced and the services were suspended. But by early on in April, there was ministry released guidelines to start services back on. And the guidance continued to reopening, reimagining service delivery, and ensuring that services reach. But come March 2021, then again, COVID-19 second wave hit. And this time the effects were much more devastating compared to 2020. So what does this all mean? How did this all end up in actual on ground level in terms of utilization of services? So we used, from here on, I'll use two data sources to characterize what it looks like for the service delivery. We had conducted own surveys between August and October of 2020 in collaboration with multiple partners in 7 states. We interviewed Anganwadi workers, ASHAs, and ANMs to understand delivery of services. And in addition, we have analyzed data from the HMIS, Health Management Information Systems, and those data are publicly available. And we looked at the data from November 2019, which is pre-COVID, until May 2021, which was after the second wave, a little bit around the second wave of COVID. And what we find is that here I would just like to bring your attention to the orange bars that are the way we have asked the questions of the frontline workers is how were you did you deliver the service and how were you delivering it during April of 2020, which was the lockdown period. And then we asked them how about the service delivery in the month prior to the survey, which is between July and September. So the green bars are or yellow bars are about April, and the green bars after the lockdown was lifted. So lower proportion of Anganwadi workers reported conducting BHND in April 2020 in all states, except in Chhattisgarh and Orissa, where more than 70% reported conducting it, even during the lockdown period. And then after the lockdown was lifted, as you can see that majority of frontline Anganwadi workers reported that they were conducting BHND. Looking at the IFA supplementation, again, across states, in compared to April, more Anganwadi workers reported providing IFA supplements in after the lockdown was lifted. Similarly, if we look at the food supplementation intervention, nearly all Anganwadi workers reported distributing food supplements in April as well. So in April also, if we look at these yellow bars, more than 60% have reported that they were delivering food supplements to beneficiaries. Except it's more in, I think in Madhya Pradesh, Uttar Pradesh, and Bihar, there were fewer Anganwadi workers who reported. But once the lockdown was lifted, pretty much 100% Anganwadi workers reported providing food supplements. Looking at the growth monitoring, again, similar patterns. In April, the fewer Anganwadi workers reported providing conducting growth monitoring. Of course, Odisha and Chhattisgarh remain an exception. And fewer Anganwadi workers report. And in between July and September, more Anganwadi workers reported resumption of services. The exceptions were in Tamil Nadu and UP. In terms of counseling, majority of Anganwadi workers in several states reported providing counseling in April as well as in July and August, except in UP and Bihar, where in April fewer Anganwadi workers reported doing so. In terms of conducting home visits, again, in April and August, majority reported conducting home visits, except during the lockdown, only less than a third of them reported doing so in UP. So when we asked how the frontline workers were actually delivering these services, certain adaptations came into picture. So instead of delivering food supplements as usual at the center, majority of Anganwadi workers reported delivering the food supplements to the beneficiary homes. In Telangana and in Bihar, some Anganwadi workers still reported that they delivered it through the center as well. When it came to counseling, majority of Anganwadi workers reported counseling during home visits. So that's an adaptation that they made. Since they were visiting homes, they were also providing counseling. Now, looking at the HMIS data itself, the monitoring system, it reflects similar findings. And here we have data available for across India. And when you look at this first map, this shows the disruption during the first COVID wave. The percent change between April, May 2020 and November 2019. November 2019 is pre-COVID, and April, May 2020 is the lockdown period. So what the red areas indicate disruptions, and the green areas indicate restorations. So service delivery was disrupted in almost 77% of the districts in the country during the lockdown. Now, come to the second map. Between November and December of 2020 and April, May of 2020, we see that services have been restored. We see the green colors, right? And then when you come to the third map, and this looks at November, December 2020 and November, December 2019. That is comparing it to pre-COVID. And here we see that the services got restored, but restored to pre-COVID level in only about 46% of the districts. That means we have not reached the pre-COVID levels yet, and this was only in November, December of 2020. But here, when we compare compared to November, December of 2020 to April, May 2021, when again the second wave hit, then the service delivery again got disrupted. So what this tells us is across board, there have been intense service disruptions. So we have to make attempts to ensure that we restore these services. Until now, we have looked at what the impact has been from a supply side aspect. Now we also want to check and look at what has been COVID's impact on service utilization as well as food security. These data come from a study in Uttar Pradesh in 2 districts. And we have been doing a study in over there for a few years, and we have had information from December 2019, which is pre-COVID, and that's why we could ask the women about various service uptake in April and ask about later on in July as well. And what we find is, if we look, this dark green bar indicates the services in December 2019. This one, the light bar indicates in the middle of April, when during the lockdown period, and this after the lockdown was lifted, the light green bar. So across all the services, what we noticed is between 2019 in December, the service utilization has declined. Women report, 53% of women reported attending DHND in 2019, whereas only 16% reported attending DHND in April 2020, and only 22% after the lockdown. So a similar pattern is observed in receipt of counseling, in receiving of home visits, in and as well as in child health and nutrition services as well, whether it is using growth monitoring services or immunization services, from 85% in 2019 to 18% in 2020. And similarly, 84% to about 40%. So what this tells is that although there have been restoration of services, we still have to understand whether the beneficiaries are actually coming and using those services. And this could be related to various factors of fear of lack of transport, fear of contracting disease, anything. So, but we need to know a little bit more about that. And when we looked at the household food insecurity itself, again, comparing before the pandemic in December 2019, indicated by the light blue bars, and then during the pandemic, which is in August 2020, the dark blue bars. So overall, if we just first start looking at this bar, any food insecurity in 2019, these households report 21% reported having any food insecurity. But in 2020, it was 80%. In August 2020. That's a huge increase. And across different domains of food insecurity, mild, moderate, or severe, there has only been a rise. And when we look at the other domains of anxiety about uncertainty, yes, there has been an increase from 12 to 45%, insufficient quality from 18 to 78%, and insufficient quantity, 14% to 48%. Concerns and anxieties related to that. And so household food insecurity increased sharply, and most of it is stemming from the quality of access to quality food than the quantity. And a broader survey of food insecurity about food security status and income and employment that has been recently published in early 2020, and this is a synthesis of findings from across multiple surveys and multiple rounds, as shown in this particular table. That suggests that there has been steep decline in income. About 80% of households were affected, and there has been increase in unemployment in April, May 2020. That's not a surprise to anybody. And then the large-scale unemployment and income loss continued in the end of 2020 as well. Now, so this continued, so we need to know what is happening actually now. And in terms of solutions, the Manrega program expanded and nearly 50% compared to the previous year. So that is actually telling us that the unemployment increased, but the social safety net program is also there, and that its take-up also has increased. In terms of food insecurity, the food insecurity levels have been variable depending on the survey and the time period. In April and between April and May 2020, the range was between 26% to 77%. In September and October 2020, 66% still reported eating less nutritious food. And this is a cause of concern, right? And then food grains from the PDS have been use of taking up of those has doubled between April to November 2020. So that is also saying that there is a need for the social safety net programs to help mitigate the effects of COVID-19. So just before I close, I would like to point out to some of the limitations and the research needs which which are needed still. In terms of limitations, we do not, from the monitoring system, what we do not know is about the extent of food supplementation, growth monitoring, and counseling. What we know is from the health side of things about antenatal care, immunization, etc. But about these interventions, we do not know what's happening there. And we do not, we are unclear if the extent of disruptions that we are seeing from the HMI system is because of its true disruption or because of underreporting due to pandemic challenges. The extent of beneficiary challenges is still not known, and households lost a lot of livelihoods. There have been economic shocks. We do not know the extent of food insecurity and lack of diet diversity yet. So there is an imminent need to actually have information collected, research done on utilization of services, on access to social protection programs, and on food insecurity. So in closing, I just want to bring back the concept that nutrition is a multi-sectoral issue, and we have to work on all the aspects. There are no magic bullets, and the exemplar state case studies give us the lessons on what can be used, what we are learning from these states can be applied. And yes, we can achieve improvements. COVID-19 has put a dent in the progress because of various disruptions. We still do not know the levels of these disruptions. We need to learn more about it. And we have to focus our efforts on restoring the services that got disrupted, bringing and trying to do this with quality and also bridging the inequalities. And evidence and engagement will have to remain central to all these efforts. Thank you for listening. And if you would like to learn anything more, here is the website and email addresses. Thank you.
Thank you, ma'am, for your wonderful description of the important topic. Now we have Dr. Najam, sir, Professor of Community Medicine, Jain Medical College, Aligarh. I have the privilege of introducing sir to the speakers. Sir has more than 40 years experience in teaching and review of many renowned journals like Indian Journal of Public Health, Indian Journal of Community Medicine, Indian Journal of Community Health, and Indian Journal of Medical Research. Sir is also a member of IPHA and IAPSM. Sir has received awards like Radhakrishna Best Teacher Award in 2010. He's also a fellow of IAPSM 2014. Sir has more than 130 publications in national and international journals. Sir has contributed to many books, and sir is the editor and course writer in Bridge Course Program in Community Health for Nurses, School of Health Science, IGNOU. He also developed 31 e-modules for the subjects of social medicine and community health, e-Pachala program, Ministry of MHRD, Government of India, as a subject coordinator. Sir, I'm so privileged to introduce you. Please introduce the next speaker, Dr. Arjun Diwakar, sir. Please display Dr. Arjun's CV.
Okay, good afternoon, everyone. And I'm going to introduce the next speaker, Dr. Arjun Diwakar. He is the Chief Nutrition Section, UNICEF, India Country Office, New Delhi. And he joined UNICEF in March 2017. And his experience says that he's from national of the Netherlands with over 27 years working experience, including 21 with UNICEF. So, sir, that's a big service for public health. Awards, fellowship, and significant contribution. Worked at country level in Zambia, Malawi, Zimbabwe, Netherlands, Namibia, Nigeria, India, region level East Asia and Pacific, East and Southern Africa, UNICEF, New York headquarters. Worked at country level Zambia, Malawi, Zimbabwe, Netherlands, Namibia, Nigeria, India, region level, East Asia, Pacific, East and Southern Africa, and UNICEF, New York headquarters. That's absolutely wonderful, sir. So you have a lot of experience, and we would love to hear from you on your topic, reflections on preventing and treating severe acute malnutrition in India during and after COVID-19. Questions can be taken after the session as designed in the SOPs. Thank you, sir. Hand over to you.
Thank you very much, sir, and a good afternoon to everyone. I'm going to build on the previous speaker, Rasmi, who very elegantly provided the evidence that is available, and actually basically providing most of the evidence that we have collectively available on the impacts of COVID on nutrition. And as you've seen, a lot of the evidence that is available is mainly in the area of access, on the impact on the access to services, and the situations at the household. Still very little information is available on the nutritional status of women and children. Of course, you need data collections, and then you need a baseline and continuous data collection to monitor that. We hope that some of the routine data collection could assist if that's available, for instance, through the portion tracker, but also further survey data. Global estimates say that COVID might increase wasting or severe acute malnutrition, including severe acute malnutrition, with anywhere between 10 and 20%. So let's say about 15%. If we take that into the context of India, of course, you talk about an additional disaster, because we all know that wasting is one of the more dangerous forms of malnutrition. At the same time, we should also be realistic, because this happens in a background where wasting levels in India are already high. We already have, well, depending on which survey you use, 17% CNNS or NFHS4, 21% child wasting, which is already very high. So the numbers, if you would calculate this to caseload, CNNS would come to about 5.5 million, and NFHS4 you get to about 8 million. For me, there are big difference. Is it 5 million or 8 million? But programmatically, it doesn't make a difference. And that is, and I'll show that later. At the moment, only about 200,000-300,000 kids are receiving support, are identified with SAM, and are receiving support to manage the SAM. So, yeah, as COVID might make that worse, we have to recognize that we have that with a tremendous background of SAM. Why I'm focusing on SAM? Well, because that could be potentially be a further impact, a further significant impact because of COVID. I'm rather pessimistic about the impact of COVID. I'm afraid that the impact will be much longer, will go way beyond first, second, third, fourth wave. 2 points that I'm really concerned about, besides with what Rasmi presented in her logic framework and the determinants of how COVID affects nutrition. I'm particularly worried about leadership. The level of leadership that we had in Posh and Abidjan, and we have not yet come back to that. And resources, financial resources. Will we have the same financial resources that we started seeing being generated because of Posh and Abidjan? Yeah, but it looks like that a lot of the additional resources we started seeing coming in 2 years ago might not have continued at the same level. If you look at severe acute malnutrition, and the Council has been working on this for a long time, and for a long time also the issue of RUTF has been put at the center. And for me, that has been completely the wrong kind of debate. People started arguing, should we or should we not, or how should we give ready-to-use therapeutic foods? And what I will be presenting today is it's not about RUTF or the food. It's about the child with acute malnutrition. What can we do there? Also programmatically, about 5, 6, 7 years ago, the responsibility also for community-based management of acute malnutrition moved from the Ministry of Health to Ministry of WCD. Interesting to see that since about a year, SAM, addressing SAM, identifying children with SAM is on the political agenda, also in the Ministry of Health. Ministry of Health, but also in the Ministry of WCD. And you see that, for instance, we're now in the 4th week of Poshma. The focus in the 4th week of Poshma. Every week in Poshma had another focus, and the last week is focusing on identifying children with severe acute malnutrition. And in my presentation, I'll focus on, okay, we have the child with SAM, what now? And that is important as a response because of COVID, but of course also will continue being important when COVID will be gone at one point. First of all, let's look at mortality rates and SAM. And we always say that SAM or severe wasting increases the risk of mortality. And yes, that's true. But in particular in South Asia, we see that actually while wasting is extremely high and higher than anywhere else in the world as a region, including, by the way, in India. In India, it's even higher than the average of South Asia. The mortality rate is lower than in what we see in some of the other countries. So even in children with SAM in India, the mortality rate seems to be somewhat lower than we see. And for me, this is a very interesting graph. Here we have wasting level percentage by age. And let's first look at the orange one, which I would call a typical pattern of how wasting increases from about 3, 4, 5 months onwards. That's the moment that complementary food is often being introduced, despite that exclusive breastfeeding should continue, but also the child starts crawling around, putting the hands in the mouth, starts getting diarrhea. You really see, like stunting in India, yeah, because the stunting has got the same kind of shape as the orange one. You start seeing this bulging, this increase of acute malnutrition from about 4, 5, 6 months onwards, with this peak of about 2 years, between 1 and 2 years. However, in India and South, we see that in many parts of South Asia, actually acute malnutrition levels, if you use weight for height as the indicator, is really, really high at birth. And for the region, it might be 14%. If you look at overall wasting using weight for height, in India, it even goes all the way up to 30%. You can see that here, the overall wasting is about 30%. So again, it's a very different shape. And that's important to recognize. If you look at the global guidelines addressing SAM, there's a strong focus on children after 6 months. And of course, because that's where the prevalence is higher, where the prevalence is increasing, and of course, where also the caseload is higher. But if you would look actually in India, that's not the case. You really might, or South Asia in this case, but then also here you see in India, you really see that the prevalence is much higher at an early age, and starting programs in 6 months is rather late. But if you go to the global guidance and the WHO guidance, and the UNICEF guidance, and the global thinking, there has been a very, very strong focus on 6 months and onwards. This is a heat map done some research from India, and every line is one child, and they started plotting the episodes of wasting. And actually, you see that many of the children who have wasting at 6 months or 12 months or 40 months, many of them also had wasting at an early age. And I call it persistent wasting. There's no permanent recovering, or there's short-term recovery, but then again, they go back. So it really looks like that, well, probably what happens at birth and the first months thereafter, largely can predict a lot of the wasting thereafter. And a further analysis has been done on this. 2 different data sets, 2 different groups that have looked at it. And the overall conclusion is that indeed, all the wasting you see at 12 months, so of all the children with wasting at 12 months, 2/3 already had wasting also in the first 6 months. So I say it again. Yeah, of all the wasting we see at 12 months, 2/3 of that was already, those 2/3 of those children also had wasting in the first 6 months. And that's important because it basically means you can predict a large proportion of which kids will get wasting or are most likely to get wasting at a later age by looking at what is happening in the earlier months. Another brief sidestep, and that is seasonality. And here you see the colored ones are analysis of the data sets of NFHS, the RSOC, but also the CNNS data, which was collected over a period. The CNNS was almost 1.5 years, 2 years almost of data collection. And we started plotting the wasting levels by month. And actually what you see is a very clear association between the timing of data collecting in what time of the year and the prevalence. And overall, you see that the wasting prevalence ranges from 24 and 12, between 12 and 24%, depending on the season the data is collected. And that's very important because often we compare surveys, but you cannot compare any survey on wasting if you don't correct it for the season when it is the data was collected. Was it in the hunger season or was it more in the season where people did have food? And that impact is much larger than people realize. Yeah, and that seasonality actually can explain a lot of the variations we've seen between surveys. So what do we need to do? And actually partly building on what Rasmi had, and Rasmi had this circle highlighting that if you want to focus on the children around the 1,000 days, you have to look at a lot of existing programs. And many of you know this slide from Dr. Vino Paul, basically mapping all the programs around the 1,000 days, including also care for severe acute malnutrition. Interesting, even Dr. Paul, and I think that if he would have to redo it, I'm sure he's going to put it at birth already. Yeah, that's the one with the green circle around it. But I would actually argue that if you would implement many of these programs, you don't need vertical programs to address severe acute malnutrition. At the end, it all needs to start with active case finding. Yeah, so let's find the child is SAM or MAM. Some children have got complications, need to go to facilities, and some children don't have complications, and that's the majority. We estimate based on global data, at least 9 out of 10 of the children in India. I think in India, it might even be a larger percentage. My hypothesis, children might not need to go to facilities. They can be managed at the community level because they don't have other severe clinical problems. But let's not forget the prevention. There's a lot of prevention that also needs to be part of this cycle. No child with MAM should ever get SAM. And here you do growth monitoring. You find children with SAM, well, let's manage that. But you also find children with MAM. Well, there's no child that gets SAM without first having MAM. So can we please do something for these children with MAM as well? Can we provide care and support and link them to existing services? But also a child with SAM, we know, is more likely to get SAM again in the future. So if you want to have targeted prevention, focus on the child with MAM, focus on the child with SAM. And then you have a very targeted prevention, including focus on the children that have SAM or a particularly low birth rate in the first 6 months. Yeah, and I think that's really why we need to start focusing on much more. It is not about the children after 6 months. We really need to get our act together around for the children that start with low birth weights, or maybe you can even start with malnourished mothers. But if you look at the children, let's start with the children with low birth weight. And again, there's a whole series of programs already in place, but children are being lost. They might receive kangaroo mother care, but they might not go to the MA program. They might not receive the home-based young child care program. They might not be part of the home-based newborn care program. So this interface between, even in the Ministry of Health, the vertical programs is often failing. And I'm not even talking here about services by Ministry of Health and the Ministry of Women and Child Development. If you look at FSAM, facility-based management, we see that a lot of centers for facility-based management have been set up. I think that the infrastructure in India is still too limited. We talk on average about 1.5 centers per district, which still means that the distances are very large. Yeah, and many women Fathers will not bring a child, and we see that many they do not bring a child with severe acute malnutrition to the centers. At the same time, in the absence of community interventions, a lot of children that don't require admission are brought to the NRC because there are no community interventions. By the way, we have seen also because of COVID that many of these centers were actually closed, in particular in the second wave. In the third wave, we see that more centers are being kept open. And that quite a few states have now issued guidance for the third wave. Please keep your NRC open. Or take care that there are beds to manage children with acute malnutrition. It doesn't have to be even in NRCs. Let's be honest, also in pediatric wards, you can manage wasting. So what needs to be done at community level? Well, you need a monthly screening, assessment, medical complications, give the medicines, do the deworming, the IFA, which is the folic acid, the vitamin A, counseling support of the family, regular growth monitoring, refer for medical complications, and provide nutritious, high nutritious, dense foods for managing the SAM. And this is the intervention. The intervention is not RUTF or not RUTF. No, it's about nutrition dense foods and this whole package. And many of these components can be done. Even the food, if you don't have specialized foods, give the best possible food. Take care that the child at least gets a very nutritious take-home ration, for instance, or maybe even a double ration. And there's also here a link to a publication that was done that did a mapping of all types of food being used in India and analyzing what is the nutrient density of these kind of foods. Are they suitable? And how far are they from the global standards for RUTF? Yeah, and could we use some of these foods? I think that way there's a lot of learning already in place that states and actors can work on. There's a whole system of centers of excellence for about 12 states have an aim or an academic institute that have got capacity to provide technical support to state level partners, to districts on how to do training, how to develop state level guidelines, state level protocols to roll out programs for the prevention, the facility and community level management of acute malnutrition. And here again, please look at the link, the Center of Excellence SAM network, where you can find so many tools, so many materials, very, very useful, in particular as national guidelines on FSAM are relatively old. They're being updated as we speak. And national guidelines on CMAM don't exist yet, but at state level, there's a lot of information already there. Coverage, uptake, you see 2018, 2019, an increase of FSAM and CMAM. FSAM significantly going down last year, and that is really because of COVID. In spite of that, CMAM services going up. And if you look at this year, and if you would double what we see in January to June, we see a significant increase of CMAM coverage. And as I look at the last few months, in particular last weeks, you see so many districts have started issuing guidance for addressing SAM. And I think it's very much because of COVID that people realize these programs are important, but also the guidance and leadership by the Ministry of Women and Child Development, that he needs to do the screening, and then of course also linking these children. And this is a summary of what is happening here in about 10, 11, 12 states. What kind of programs do they have? At what level? In some states, it's still at block level or pilot, state district level, where they try to pilot, like in Jharkhand or Bihar. But also other states that have already started scaling up. Telangana has come up with Balamrutam Plus, an extra nutrient-dense food being distributed to all the children with SAM they can identify in the state. Madhya Pradesh going to scale as well. And actually, even this slide needs to be updated because of what has happened in the last few weeks. So I would say SAM and addressing SAM is important because COVID makes it worse. But even without COVID, there was a big challenge. I would also say we don't need a vertical new CMAM program. We can build on existing programs, existing schemes, but ensure that they reach the child and provide this continuum of care, the continuum between the different programs and schemes. A child should not be lost between the different programs. Yeah, and the prevention. We can prevent almost all SAM after 6 months by even looking at the children before 6 months, the low birth weight babies, the children with low height or weights, underweight babies in the first 6 months. It's very much predictable what is happening after 6 months. So I would say there is not much new investment to be done. This doesn't require a technical solution. There is no time to waste. Children with wasting today cannot wait till tomorrow. I thank you very, very much.
I request Dr. Najam to introduce our next speaker, Dr. Sarika Yunus. Please show the CV. Sir, you have to unmute your audio, sir. Oh. Thank you, sir.
Now, the next speaker is Dr. Sarika Yunus. She is working as a nutrition specialist in head nutrition and school feeding, United Nations World Food Programme. She graduated in medicine from JN Medical College, Aligarh in 2001, a gold medalist in community medicine, a diploma in public health nutrition from Public Health Foundation of India. Her awards and significant contribution are maternal and child health, infant and young child feeding, and links between disease and nutrition. She's trained on the management of nutrition in emergencies by the University College of London and Asian Disaster Preparedness Center. The ASHA project under the National Rural Health Mission with the Training Division, Ministry of Health and Family Welfare, Government of India. She has worked as the focal point for nutrition at the WHO Country Office for India. She has to accredit several research papers in various national and international journals. She'll be talking on the topic India food-based safety nets and the COVID-19 pandemic. So I request Dr. Sarika to please start her presentation.
Thanks a lot, sir, for that kind introduction. I'll just try and get my screen slides up in a minute. I hope my slides are visible. At the outset, I'd like to thank the Indian Public Health Association for including a session on public health nutrition in the fold of this conference, as well as for giving all of us an opportunity to engage with you on different aspects of nutrition. I'd also like to thank especially the chair of the session, who's also my teacher, for the extremely kind introduction. And I do hope that I'm able to live up to what's been taught to me during my stay at JNMC. I'll be talking about the food-based safety nets and COVID-19. There's been a lot which has been said by the previous speakers. My focus in the presentation would be on the food component of the food-based safety nets, how that's evolved in terms of the government response during the period of the pandemic. Just to reiterate points which have already been made by Rasmi, but perhaps at a higher level, that we all know that COVID-19 has impacted food security and nutrition by affecting food availability, both in the short term and long term. The supply chains have been disrupted and the supplies to the food-based safety nets as well. Production capacities have been affected, access issues have been compromised because of loss of livelihood and therefore decrease in purchasing power. There's been limited diversity on the plate, and there's been a shift because of the various actions taken in the form of the lockdowns to more shelf-stable and prepackaged foods. And the markets as such have also sort of reacted adversely to the various incumbent measures of the pandemic. There's been a high amount of instability in the market, leading to a certain degree of uncertainty. And in the middle of all of this, the poor and the vulnerable have been affected much more than the rest. Now, when we talk about India's food-based safety nets, India has some of the biggest food-based safety nets on the globe. All the three food-based safety nets are covered under the National Food Security Act 2013, which makes the access to food for 67% of the Indian population a constitutional right. The National Food Security Act sits on the pillars of three schemes. The first of which is the targeted public distribution system, which has a reach to about 800 million of our population, wherein there's a monthly ration which is provided to priority households and the poorest of the poor households. Then we have the midday meal scheme, which in global parlance is referred to as the school feeding program. It covers children with a hot cooked meal between the ages of 6 to 14 years, which basically translates into children studying between grades 1 to 8. Then we have the supplementary nutrition under the ICDS scheme, wherein there's a take-home ration which is provided to children between 6 to 36 months of age, a take-home ration which is provided to pregnant lactating women, and ideally children between 3 to 6 years of age should be receiving a hot cooked meal. What you can see also here is that the food-based safety nets that we have in place in the country, which are gigantic by any stretch of imagination, also follow a life cycle approach. And the focus is on covering almost all the key vulnerable phases of life from a nutrition perspective. Now, in the forthcoming slides, I will dwell on each of these schemes one by one. In terms of what has been the government response during COVID-19 pandemic, how effective have those responses been, and then what have been the challenges with the response that has been in place. So the first in the series would be on the targeted public distribution system. Just get all the points up in one go. So when the pandemic was befell in March last year, and there was talk about the first lockdown, the government very quickly came out with a response as far as the public distribution system was concerned. There was a push for the PDS food rations to be delivered at home for the ones who are vulnerable. There was an advance allocation of about 6 months of grains, which was allowed in one go. So that there isn't any break in the supply chain. So they were already thinking of supply chains when they came out with this decision. They also were aware that given the lockdown, there would be hoarding attempts, and therefore states were asked to strengthen local market intelligence. States were also asked to suspend the use of the point of sale devices. The point of sale devices are devices which have been introduced at the fair price shop to reduce the leakages and pilferages in the targeted public distribution system, and to also ensure that the PDS beneficiary gets what they are entitled to get. Given early on in the pandemic, there was a lot of focus on surface transmission of COVID-19, so the government also suspended the use of the point of sale devices. There were additional commodities which the government agreed to distribute through the fair price shop in the form of an additional 1 kg of pulses per household per month. And there were additional allocations in terms of an additional 5 kg of grain per person per month for 3 months, which was supposed to be free of cost. A lot of these interventions then got clubbed and came to be known as under the Pradhan Mantri Garib Kalyan Yojana. And what you can also see here is that the allocations under the Pradhan Mantri Garib Kalyan Yojana were made, and you can also see the offtake figures. And the allocation and offtake figures seem to be fairly closely aligned. These would not have been the figures under normal situations. So the dependency on the food-based safety nets for the general people, for the community, actually increased during the COVID pandemic. There were also other initiatives which were put in place by the national government, which included the Atmanirbhar Bharat scheme for the migrants. Post the first lockdown, there was a huge migrant crisis with people traveling thousands of kilometers from one part of the country to reach their homes. And there was initiatives which were put in place to cater to this migrant crisis, including the additional allocation of 5 kgs of grain. There was also a scheme called the One Nation, One Ration Card scheme, which came into being. During the early 2020, this scheme was at a very initial infant stage, but during the pandemic, it has been ramped up. And what the scheme in a sense allows is that if there's a migrant from Uttar Pradesh who's traveled for work down to Kerala, he can still access his PDS allocations despite being in Kerala. So it enables a certain level of PDS portability across the country. And there were also initiatives which were taken on liberalization of the open market sales scheme. There were certain state level initiatives which were also taken by different state governments across, which involved setting up of community kitchens. And you can see that they were set up in different parts of the country. There were also state level initiatives such as those taken by the government of Telangana, where 12 kgs of rice was provided to all ration card holders, along with an additional 1,500 rupees to buy groceries and vegetables. There were also interventions which were put in place by the government of Odisha, including setting up of free kitchens in every Gram Panchayat. However, despite this, let's say, quick response by the national government, on ground, there were huge issues and challenges in terms of limited reach and distribution. Initially, there was a huge lot of confusion in terms of distribution without the use of POS device, distribution without biometric identification and the legal documentation and the linkage to Aadhaar, etc. So some of those technology glitches also limited the reach of the overall scheme. The ration cards, as I spoke, were linked to the place of origin. And the focus of distribution through the PDS, despite the 1 kg of pulses, was largely serial-based. And there was also some criticism that it was not perhaps enough given the requirements. Now, coming to the midday meal scheme, the midday meal scheme, as I spoke earlier, caters to children between the ages of 6 to 14 years, translating into children studying between grades 1 to right up to 8th. And for the midday meal scheme, there was a suo motu cognizance which was taken by the Supreme Court of India. However, this, in sort of parallelly, there was also, because it is covered under the National Food Security Act and the MDM rules, there was already a provision of food security allowance to these school children. The food security allowance consists of provision of in-kind grains as per the entitlement of the child. For younger children studying between grades 1 to 5, this translates into 100 grams of grain per day. And for the elder children studying between grades 6 to 8, this translates into 150 grams per day. The food security allowance also allowed for the transfer of cash equivalent to the cooking cost per child into the bank accounts of the school children. Where it could not be transferred for various reasons into the bank accounts of school children, there was a provision to pass on an equivalent food basket consisting of other food items such as pulses, oils, etc. Here again, the national government was immediately responsive in terms of issuance of guidelines to the states. As early as March 2020, there was a guidance which was issued to the states and union territories to provide for hot cooked meals in schools or for food security allowance, depending on the local situation. The midday meals are generally not provided during the summer vacations, but in April 2020, a decision was taken to continue to provide the midday meals during the summer vacation. There was also, I would say, the Ministry of Education at the national level was responding fairly quickly to the requests or the issues that were coming on the ground in the different states. And they noticed that perhaps in provision of grains and in provision of cooking pots, perhaps nutrition was being compromised. And there were guidelines also which were issued to ensure that the nutritional requirements of children are met. In October 2020, there were guidelines which were issued to allow for opening of schools, but with parental consent for children to be sent to school. In May this year, during the summer vacation, the decision this time was not to provide the midday meals as such, but to transfer the cooking cost of the midday meals into the accounts of the school children, because the provisions through the Pradhan Mantri Garib Kalyan Yojana still continue to be in place for the different members of the family. As the World Food Programme from March 2020, almost on a quarterly basis, we've been tracking the implementation across states as far as the midday meal and the ICDS food component are concerned. And our latest tracking findings for the period April to June, and this may not necessarily be true today, point to a couple of key issues. One, that the elementary schools were closed in almost all the states and UTs in April 2020. April 2020 was right in the middle of the second wave of the pandemic, and the schools then continued to be closed during May and June as well, which was largely because it overlapped due to the summer vacations. The midday meal in one form or the other, and when I say one form or the other, I mean either as a food security allowance, cash or dry rations, or a food basket, was functional in one form or the other in 35 of the 36 states and UTs. We do not have information on how functional it was in the state of Telangana. But the understanding is that since there were other provisions which were made by the state of Telangana, therefore it may not necessarily have been functional there. Most of the states, about 19 states and union territories, were providing dry rations and other food items. And about 16 states and union territories were providing dry rations along with the cooking cost. These were provided to almost all the states, covering except for the period during the summer vacation. In line with the national guidance, again, most of the states are in the process of providing the children with the cooking cost during the summer vacation, but action on it for now seems to be limited. Now, key challenges that we found in several states and union territories was that there was change in priority, and the governments were really busy in tackling the education component of the fact that education also was disrupted because of COVID pandemic, and therefore the focus of the school teachers, etc., was more on that. It was an unprecedented crisis by all comparisons, and therefore it was difficult to make logistic arrangements. There was huge delays in terms of on-ground implementation. The guidelines may have been issued both at the national level and also at the state level, but in terms of actual implementation of those guidelines, there were huge delays. We also feel that early on in the pandemic, there was an impact on other complementary health services. But as you would recall from Rasmi's presentation, that this started picking up once the lockdowns were called off, and more or less started becoming equivalent to perhaps the pre-pandemic situation. And there is lack of a scientific monitoring system to actually understand or track the on-ground distribution. The last scheme that I'll be talking about, and I'll only be covering, is the food component of the ICDS scheme. Here again, there have been several guidelines which have been issued at the national level. There have also been guidelines which have been issued to create awareness around the COVID-19 protocols as a part of Poshan Abhiyan and as a part of Jan Andolan under Poshan Abhiyan. In April 2021, there was a guideline which was issued because learning from the delays in implementation on ground, that the Anganwadi workers were guided to distribute take-home rations. Even the hot cooked meals which are given to children 3 to 6 years of age were then converted into take-home rations, and they were guided to distribute these take-home rations at least once every 15 days at the doorsteps of the beneficiaries. Just like we were tracking the MDM and how it was performing at the state level, as the World Food Programme, we've also been tracking the food component of the ICDS, and the data that you see here is again for the period April to June 2021. In terms of reopening of the Anganwadi centers, during this period, we found that almost all the Anganwadi centers were closed except for the state of Chhattisgarh. The states had state-specific standard operating protocols in place developed for 4 states for opening of the Anganwadi centers. And the Anganwadi workers in most of the states were tasked with the distribution of the take-home rations. The other findings included that there were a variety of food items which were being provided by the states and UTs. most of the frontline functionaries during the period for which we collected data also reported on having received the COVID-19 vaccines. The 17 states and union territories were also beginning to implement these preschool education component of the ICDS scheme. In terms of the distribution of the take-home ration, about 22 states were organizing doorstep delivery of the take-home ration, but the frequency varied between once a month to once every 2 months. About 6 states were organizing the delivery of the take-home ration at the doorstep on a weekly to fortnightly basis. And in about another 6 states, it was being collected from the Anganwadi centers by the beneficiaries. In terms of what was being provided, about 15 states and union territories were providing dry rations as a part of the THR food baskets. 13 states and union territories were providing a dry ration and a ready-to-eat food basket, food as part of the THR basket. In 7 states, eggs were also being provided as part of the THR basket. And Chhattisgarh was probably the only state that provided hot cooked meals along with THR, since the Anganwadis continued to remain open for the preschool children. Here again, as responsive as the national and state governments may have been, there were issues on-ground implementation. With the food as dry rations and often being given as cereals and pulses being given to families, there was sharing of the food within families. So though the food may have been targeted to a particular member of the family, the entire family shared the food. There was an increase in the number of beneficiaries because of a lot of reverse migration which happened. A lot of it was also because there was doorstep delivery. The frequency of distribution we've already discussed. Most of the states, initially when the take-home rations were being given to children, they were being given to children either as a blended food, but most of the states went back to giving it as dry rations, which consisted of wheat, grains, pulses, oils, etc. And therefore they started procuring these from multiple sources, which led to a lot of confusion and delays in on-ground implementation as well. Again, in terms of tracking what actually got delivered, there seems to be gaping holes there. In terms of governance issues, as far as the implementation challenges are concerned, there are several states which have talked about lack of protective gear for the frontline functionaries, and also that the frontline functionaries were overburdened because they were also pulled into a lot of COVID related tasks such as contact tracing, counseling, etc. for vaccination. So with that, I end my presentation, and I hope I've been able to give a wholesome perspective of how the food-based safety nets were impacted because of COVID. Thank you so much.
I requested Dr. Najam to ask questions or give your concluding remarks, sir. Sir, your audio is mute, sir, once again.
Now, all the 3 presentations were very good. And this is, again, a very important part as far as India is concerned and other developing countries are concerned. Because during the COVID time, we had all seen, mostly through print media or electronic media, what happened to the migrant workers also. And whenever they started reaching to their homes also, this was a huge problem. So all 3 have actually dealt out in detail what the government is doing, what they are doing. And it is very important to reach out to the global targets and focus on nutrition. And committed to improve child nutrition, that should be very important as far as we are concerned. There are multiple determinants that need to be dealt, and the all 1,000-day program, that is also very important. Implication of COVID-19 impacted malnutrition affected every segment of society. And the role of grassroots level workers is very important in achieving targets. And we should also understand that nutrition is a multi-sectorial issue, and a focus effort is required on this. So once again, thank you all. It was a pleasure being as one of the chairpersons for this plenary session.
Thank you, sir. On behalf of our organizing secretary, we also thank all the excellent speakers for sharing their valuable experiences. I also very grateful and thank you, sir, for chairing this session. Thank you so much, ma'am, Rashmi ma'am. Thank you, sir, Dr. Arjun, Dr. Sharika Yunus. It was very wonderful to go through your experience. So since I'm also interested in maternal and child health, and that nutrition part is very attractive to me. So I have a lot of things to learn. I'm hoping for a future interaction with you, ma'am. Thank you so much, sir. Thank you so much, sir.
Thank you.
Thank
Thank you.
Thank you, ma'am. Thank you, sir.
Thank you.
Shall I leave?
Good afternoon. How are you, Bharadwaj sir?
Fine, sir. Thank you. Fine.
Good to see you virtually.
Your outlook is changed.
Yes.
When I met you a long back in Shimla, Peterhof.
Yes, I remember. That was quite some time back.
Meeting.
Yes, that's true, sir.
It's a long back.
Yeah.
So, sir, I perhaps I will believe on your judgment. I will rely on your judgment. Okay.
No, we will.
Okay. We
go
have
separately, and then if we need to agree, then we will discuss. Otherwise, let them total it up and decide.
Because opinion can change, but your opinion should be supreme. Based on your experience, sir. Based on your experience.
Yeah, I often say in my classes on leadership that Newton watched an apple fall from a tree for a few nanoseconds, and that experience of few nanoseconds was much more important than lifelong experience of many scientists.
Yes.
So everyone is important, whatever level of professional stage we are.
Yes.
We should value it.
Yesterday in GBM, they were praising you.
Who?
In General Body meeting of Indian Public Health Association.
Oh, okay.
National Academy of Public Health.
All right. Yeah.
Whether you have done a wonderful job.
Oh, thank you, sir. Thank you.
Conducted many courses.
Yes.
Only you can do it.
So थोड़ा बहुत effort करते हैं. I don't know.
नहीं, sir.
If it is useful. How are you, Dr. Prinja?
Good morning, sir. Good afternoon, sir.
Good afternoon.
Good afternoon, Dr. Bharadwaj, sir.
और प्रिंजा कैसे हैं?
ठीक ठाक सर, सब आपका आशीर्वाद है सर.
Good afternoon, everyone. Shall we start, sir?
Yes. आप मास्क पहन के बैठे हो. There is somebody in the room?
Yes, sir. We are in the
Right.
campus now, so.
Oh, okay. हम लोग तो अलग-अलग कमरे में बैठे हैं, so we are not wearing the mask.
Yes, sir.
The only person who can infect us is we ourselves. So
yes.
For that you don't need a mask.
My name is Vignesh. I am a senior resident in Jipmer.
Okay.
Good afternoon, everyone. It is my pleasure to welcome you all to the 65th annual Indian Public Health Association conference, jointly organized by Jipmer Puducherry and IPHA Puducherry. I welcome you all to the RCTC, Resource Center for Tobacco Control in India, grand session presentations. So I would like to invite our chairpersons for this session. We have 3 chairpersons for this session: Dr. Ashok Kumar Bharadwaj sir, Dr. Sanjeev Kumar sir, and Dr. Shankar Prinja sir. Dr. Ashok Kumar Bharadwaj sir is currently Professor Emeritus, Medical College and Hospital, Solan, Himachal Pradesh. He is chairman of the National Task Force on NTEP since July 2021. He is a core group member of NTEP IAPSM. He is member of the National Core Team for Subnational TB-free certification. He is awarded with Best Public Health Specialist in TB Elimination in March 2021. He is fellow of IAPSM, IPHA, IMSA, ISHA. He has given Dhanvantri and Dr. Harcharan Singh oration. He has served as national president for IAPSM. He has more than 99 publications and 42 projects. Welcome, sir. Next, Dr. Sanjeev Kumar, sir. He is currently chairperson in Indian Academy of Public Health, New Delhi, India, and chairperson for Advisory Committee, Indian Alliance of Patients Group. He has more than 41 years of experience in public health over many countries. He has served as Executive Director of NHSRC. He was advisor to UNICEF programs in various countries. He has served as Director of IIHMR. He has received many national and international awards in recognition of his contributions to public health. He has more than 100 papers in scientific journals and contributed to chapters in books. Welcome, sir. Next, I invite Dr. Shankar Panja, sir. He is currently additional professor in the Department of Community Medicine and School of Public Health, PGMR, Chandigarh. He has over 20 years of experience in medical research and teaching with an interest in the area of health economics. He is awarded with the prestigious DC Srivastav Foundation Award for his research on universal health coverage by the ICMR. And he is one of the top 20 researchers working in the field of universal health coverage. He has more than 250 publications. Welcome, sir. So about this session will have 6 presentations. This session will have 6 presentations, which were shortlisted by an expert committee, out of which 1 presentation is to be awarded with the grant. So the presentation guidelines are, each presentation will be for 6 minutes, and the time, I request the presenters not to exceed the time limit. And there will, at the end of each presentation, there will be a 2-minute question and answer discussion by the chairpersons. And the evaluation will be based on 5 areas: public health importance, relevance and rationale, methods, novelty of the proposal, sustainability and scalability of the proposal, translatory value or policy implications of the proposals. I hereby hand over the session to the chairpersons. Over to you, sir.
Dr. Sanjeev, you start.
We can have the first presentation, or you want to say something, Dr. Bharadwaj and Dr.
No, sir. Right away, we will start with the presentation.
Okay, so we'll start with the presentations, and those who spill beyond the time limit will get a negative score.
Yes.
So keep that in mind. You will lose marks if you don't finish on time. All right, over to the first presenter.
Dr. Gilbert. Sir, you can, everyone is given the access to share their screens, so they can share their PPTs.
So is my screen visible, sir?
Yes, sir, it is visible.
Okay. Good evening, panel members and my fellow delegates. The proposal I'm going to present is titled Mapping of Tobacco Retailers in the Neighborhood of Educational Institutions in Puducherry, a Mixed Method Study. So tobacco is the single most important preventable cause for disease, disability and death among adults in India. And in 2004, CODPA has been enacted to curb the ill effects of tobacco use in India. However, it is often reported that the implementation of CODPA is very poor, and most of the time we are not sure about the enforcing authorities and what is the mechanism which has to be put in place for proper implementation of CODPA. It is important that proper monitoring and reporting mechanisms by competent authority and also periodic enforcement drives to implement CODPA is very key. We cannot always rely on national tobacco control officials for enforcing such implementations, and external agencies like Department of School Education, Higher Education, Technical Education, UGCs, and other NGOs should also come forward in identifying violation of these regulations and helping the tobacco control program to enforce these legislations. This proposal is based on the subsection ban of tobacco products within 100 yards of educational institutes, and also a part of section 4, which is banning tobacco use in public places. The objectives of this study would be to determine the spatial distribution of tobacco retail shops in the neighborhood of educational institutions, to determine the proportion of educational institutions which has 1 or more tobacco retail shops within a radius of 100 yards, to determine the proportion of educational institutions that display warning boards about prohibition of tobacco smoking and sale around the institution. And last, to understand the perception and reasons for violation of Code Pass subsection 6 by the retail shopkeepers. So this would be the objectives. For objectives 1 to 3, which is mostly pertaining to the quantitative part, we'll use the following materials and methods. We would conduct a community-based cross-sectional survey, and the study population would include all the educational institutes and retail shops in the neighborhood of the identified educational institutions. As per previous reported literature, 69% of the educational institutes violated the subsection 6B of Code Pass, and assuming that we have calculated the sample size to be 83 educational institutes to estimate the proportion which are having one or more tobacco retail shops within a radius of 100 yards from the educational institutes. The sampling will be done as follows. The list of all educational institutes, schools and colleges will be obtained from the Department of School Education and the Department of Technical and Higher Education. And the list of educational institutes will be divided into 4 strata based on the location, urban or rural, and the type, whether it's a school or college. So accordingly, we will have 4 strata: urban schools, urban colleges, rural schools, and rural colleges. And within each of these strata, the schools will be selected using simple random sampling. The number of educational institutes selected will be proportionate to the total number of institutions within each of the 4 strata. The procedure will be, the field investigator will be trained in data collection using EpiCollect, a mobile-based application which has inbuilt facility for capturing the GPS coordinates accurate to about 10 meters. So each educational institute will be mapped, and then some basic information.
You are no longer audible. His connection perhaps is gone.
Yeah, I also can't hear him.
So we have to have him give extra time.
Dr. Gilbert?
Technology.
He has, I think, lost the connection also, sir.
Yes.
So can we go to the next one, and
Yeah, we can go to the next one, and whenever he is available, yes, we can bring him in.
Okay, sir. I request Dr. Anirban to please share their presentation and start.
Sir, may I audible?
Yes. Go ahead, Dr. Anirban.
Should I start? Okay. I'm Dr. Anirban, Assistant Professor of Community Medicine at Iphacon Medical College.
Anirban, we hear some echoing from your side. You have only one device on?
Yes, sir.
You can switch off your video or video if you can.
Okay, sir. Okay.
That will be fine.
So is it good now?
Yeah, better.
Is it okay? Yes, okay, sir. Thank you. So I'm Dr. Anirban Dole, Assistant Professor of Community Medicine at Government Medical College. I'm going to present the grant proposal study, this impact of work from home during a COVID-19 pandemic on tobacco use among adult population of West Bengal. So, for the rationale of the study, we must say that work from home is considered as one of the important action by both private and government setup, and restrictions imposed have suddenly changed the lives of millions of Indians, resulting in changes in their lifestyle and as well as the addictive behaviors. So, this can lead to mental distress such as increased monotony, stress, anxiety, depression, irritability, and insomnia. So there is two kinds of questions. Maybe there is an increase in mental distress, which can lead to increase in smoking during lockdown, given the positive association between smoking and mental association. Otherwise, it can also happen that social isolation may lead to a reduction in social smoker, that is people smoking primarily in social contexts and the smoking is getting less and less. So with the objectives, we are moving forward, to determine the magnitude of tobacco consumption during work from home, to determine change in magnitude of tobacco consumption before and after commencement of work from home, and to find out factors affecting the change in tobacco use before and after commencement of work. So this is a community-based observational study with cross-sectional design, and the study area is Vidhannagar Municipality, North 24 Parganas District of West Bengal, and the study duration is October 2021 to March 2022, with the study populations or all the adult population, both male and female, more than 18 years of age and less than 60 years of age, with permanent office address as that municipality. Sample size was calculated by considering the prevalence of 23.3% as previously reported in the study, with 95% CI and 20% relative error. The sample size becomes 316, and applying design effect of 1.5 for multi-stage sampling and considering 10% non-respondent rate, it becomes 506. So now this is sampling technique. The list of private and government offices of Vidhannagar municipality will be taken. The list of offices will be prepared who are having staffs working from home only. So now we are getting 20 private offices and 20 government offices by random sampling. A list of workers of those offices who are working from home will be prepared. 15 workers from each office will be chosen randomly. So 600 people will be included, and a web-based questionnaire will be mailed to them. What will be there in the questionnaire? The questionnaire contains a pre-designed, pre-tested schedule with a visual analog scale, Pittsburgh Sleep Quality Index for quantity of sleep, generalized anxiety disorder scale for anxiety measurement, and Beck's depression inventory for depression measurement. So based on information we can get from company records like age, gender, company position, working schedule, work arrangement, type of contract, and full-time employment, whether it is full-time or part-time. And outcomes is like improvement and worsening of smoking habits. What is called improvement? Improvement of smoking means quitting smoking or decreasing smoking intensity, and worsening smoking habit includes the starting smoking among never smokers or relapsing among former smokers, and increasing the number of cigarettes smoked per day. So after ethical committee's clearance and district health authorities permission, all selected workers will receive a personal link by email and connecting a web-based questionnaire to be answered within 2 weeks. In the following 2 weeks, the workers will receive a phone call as well as emails and the weekly reminder, and survey will collect the information on this parameters, whatever we have discussed. Ethical clearances will be taken from Institutional Ethical Committee of Arjikar Medical College, and data analysis will do a chi-square test to determine the significant relation between two categorical variables, and bivariate multivariable logistic regression will be done to find out the factors affecting tobacco use. So this is my timeline. So it's starting from the October 21, and it will be commencing on March 22, and the data collection period will be 3 months. After the data checking and entry, analysis will be done at the last 2 months. And for my budget purpose, I have just selected it as salary of the telecaller. It's for 3 months salary as 15,000, contingency is 5,000, and travel expenditure as 5,000, and miscellaneous 5,000 total. These are my references.
So we can go ahead with the question. Sir, you are muted. Dr. Sanjeev, you are muted.
Yeah. Please go ahead with the questions.
So Anirban, my question too is, so how you are going to translate this project, finding of this project to the other? There was a column given to us, translatory value or policy implications. How you can?
Yes, sir. Yes, sir. Thanks for the question. Sir, actually, during the lockdown period and this is a restrictions period in several states of India, there will be work from home culture has been introduced in our society, and that will implicate that more addiction in the more smoking habits and more times of addiction habits among the people who are working from home. So it's a time to make the policy change, to make it more reliable system, so that the smoking counterpart or the mental health issues that can be taken care of, so that the people who are working from home, they will not get so much fatigue, they will not get so much anxious or depressed. So if we get our findings, like if the smoke, if the addiction is increased, as well as the mental health issues will be there, so we can just we can ask the companies, we can ask the recruiters to make some counseling sessions, and so that.
My last question is, so one of the most important risk factor is the opening of offices. So people now will be physically going to the offices. So how you are going to scale it up? Based on these conditions, how you are going to scale it up?
So still, I have just
because
checked, sir.
offices are opening now.
Yes, sir. But in West Bengal, this is an IT sector placed in this Midanagar municipality, and we have already checked the data, and we have already get some pilot study, so that we are getting this coming 3 to 6 months. The work from home culture will be going on.
Thank you, Dr. Sanjeev Kumar. Sir, muted. You are muted.
Dr. Prinja.
Sure, thanks, sir. Anirban, I just had one question. You are saying that you want to measure the impact of the work from home on tobacco consumption or on quality of life issues. What is the design that you're using in order to do that? Is it a pre and post, or is it a kind of a case and control?
Yes, sir. It is just we'll take the history. We'll take the questionnaire will be framed as such that they will give the history of like whatever they are taking before commencing of work from home, and whatever they are taking after work.
All right. Then in that case, there is a significant design issue, because the recall bias will be very strong, especially with regards to your vast illustration for quality of life and also the smoking history as well, because you're going to go back too much in time to reflect on what was the situation before the lockdown and before the work from home kind of things started. So maybe you may need to look into that.
Yes, sir. Thank you. So actually, I'm taking the tobacco consumption history before commencement and after commencement of work from home. But the other mental health issues, the mental health questionnaire, that will be taken care of recent status, only the recent status.
Over to you, sir.
All right. Dr. Anirban, my question is related to what Dr. Bharadwaj has already asked, but I'll like you to elaborate more. In terms of translation of this research into policy and future, do you think we will have lockdowns in future as well? Then we will have application of this. So what do you say on that front, Dr. Anirban?
Yes, sir. So thank you for the suggestion and question, sir. The thing is, we should be prepared for the further pandemics or further outbreaks like that, and there may be a chance of like your containment or lockdown issues, and where work from home culture will be more and more elaborate. So there can be an association of more smoking pattern. The smoking pattern of the people who are working from home, they may increase. They may maybe increase in their situation. So that if we check earlier, if we check the with the previous with your awareness sessions, we can ask the companies, the company heads, or the local municipalities, local authorities to check the spread, to check the consumption. We can take the policies.
Thank you, Dr. Anirban. We got a feel of what you want to say. Can we go to the next presenter? Thank you so much, Dr. Anirban.
Thank you, sir. Thank you so much.
So Dr. Gilbert has joined back. Can we have his presentation?
Okay, yeah, he can start from where he left.
Yes.
Sorry for the interruption. So the field investigators will be trained in data collection using a mobile-based application, Epiccollect 5, which has inbuilt capacity to collect the GPS coordinates close to accurate to 10 meters. So the GPS coordinates of the entrance to the educational institutes will be mapped, and the investigator will also record few observations related to the sign, whether signages are present in the institute, and some basic information about the educational institute as such. Next. So following that, he will also survey up to 200 meters from the entrance or exit points of the institutions in both or all possible directions. When multiple entrance points are present, all will be mapped using the same principle. And in the 200 meters, the investigator will scout for any possible tobacco retail shops. Even general retail stores will be inquired about sale of tobacco products, and GPS coordinates of the retail shops will be captured. Next. So the outcomes we will be trying to study will be, one will be the section 4 of CODPA, which is display of signages in the entrance as tobacco-free institutions, as well as banning tobacco usage in the institution. And the second outcome would be what proportion of institutions have a tobacco selling retail shop within a radius of 100 yards. We will be summarizing the result using proportions with 95% CI, and distance matrix function will be used in QGIS to capture the difference distance between the two GPS coordinates, which will be the institution and the retail shops. Next, we'll be using Stata and QGIS for the analysis. For qualitative part, we will use a concurrent nested design. A subset of the retail shop owners who violated the subsection 6 of CODPA will be interviewed to know the perception and reasons for having a tobacco shop within 100-meter radius. And also head of the institution, head of the educational institutions, and few program officials under NTCP will also be interviewed until information saturation is attained. The interviews will be translated, transcribed, and then analyzed as codes, sub-themes, and themes, and then reported suitably. Next. So the expected benefits, what we expect from this project would be, this will be an exercise to map the tobacco retail shops in relation to educational institutes using JAS. And the study findings along with the data will be shared with the enforcing authority, which is a state tobacco control program officer, for suitable enforcement with the available data. And we would also suggest that similar periodic activity can be undertaken to monitor the compliance to the defined subsections of CODPA in the Puducherry district. So this will be the timeline. We propose for 3 months of data collection, and this is the budgetary requirements. Next. Thank you.
Should I go ahead, sir?
Yes, please. Dr. Bharadwaj first, and then Dr. Prinja.
Dr. Gilbert, I have got only one query.
Yes, sir.
In qualitative methods, you have told about qualitative methods.
Yes, sir.
So, beside key informant interviews, you will be doing KI. Okay.
Will be, yes, sir. In-depth interviews with the retail shop owners.
Yeah, well, that is key informant interview. No? Then, yes, are you planning to undertake NGT also in this?
No, sir.
That will yield more information. That can yield more information. Nominal group technique. We used to call it FGDs.
Yes, sir. That is true.
Have you thought of otherwise? Because you have not mentioned it.
Yes, sir. Actually, we thought about it. The factors we considered was, one is feasibility to get all the tobacco retailers in the common place, and other thing is it's a negative factor that if they have been identified as selling tobacco within 100 meters of the educational institutes, their willingness to come forward and discuss in a group may be a limiting factor. Okay. That's why we kept it as a...
Again, my pet question is translatory values.
Yes, sir. So right now the implementation of this CODPA is being undertaken by the National Tobacco Control Program State Implementation Cell, and they are in the process of starting this yellow line campaign, that is to identify 100 meters distance from the educational institutes, which is still not implemented in Puducherry. This study may be one of a baseline assessment for assessing the implementation of CODPA in Puducherry. And the other thing would be the translatory value will be periodic. Such surveys can be taken up periodically, maybe once a year, to identify if, what is the complaints to the CODPA in this region.
Okay, thank you, sir.
Thank you, Dr. Prinja.
Yes, sir. Thanks, Dr. Gilbert. I think it was a very clear presentation. I just have one question, that besides, and this is in terms of the overall scope of your work, is there a possibility of actually adding something on the use of tobacco as well in these educational institutions, so that you could link that the risk of exposure, which is the presence of these tobacco retail shops, and the extent of tobacco use in these institutions? So is there a possibility to add that as well in your objective within the scope of the work?
Yes, sir. Actually, we have considered this, but one limiting factor what we thought was, now that the schools are remaining in closed, and it is not in full functional. All the educational, colleges are open, but schools are not yet open. But as you pointed out, that would be another important finding to correlate the extent of tobacco use and with the proximity to the retail shops. And we have considered it, and we'll try to include a few, we will try to include this aspect into the study, sir.
Right.
We'll consider collecting the tobacco use profile of the school students or the educational institute participants.
Over to you, Sanjeev, sir.
Thank you, sir.
All right, good presentation, Gilbert, especially methodology. You had gone into a lot of detail, and unfortunately the technology didn't really help us. So you dropped out in between. My question is, provided you complete the study, take yourself 6 months from now, what comes to your mind is likely to be the recommendations for policy change? Do you hear me, Gilbert?
Sir, it was disconnected, sir, in between.
Yeah.
Sir, can you?
My question, I will repeat.
Yes,
I will take you fast forward to 6 months. You are in March, April 2022.
Yes, sir.
You have completed the study. And what is likely to be the policy implication you are going to recommend out of the study?
So the policy is already there. We are just assessing how much of it is implemented, so that we can call for stakeholders meeting and plan for better implementation of the same subsections, like having a stakeholder meeting with the educational institute heads, and also educating the retail shop owners about the policy, which we may get the information from the qualitative part. What is the reasons for the perception why they are having the shops in the
give us an
locality?
idea about implementation, how well we are implementing the policy. That's good. Thank you, Gilbert. Jignesh, we can move to the next one.
Yes, sir. I now request Dr. Vinod Kumar Kalidas.
When you are calling
present.
in the person, can you also give us the number in the list you had given? Otherwise, we have to search for the name and then look at the...
Yes, sir. Dr. Gilbert is number 1, sir, in the list.
No.
Gilbert in my list, he was number 9.
I was trying to ask the Excel sheet that you had given us for scoring, in that which is the
number.
Sir.
I have sent that in the afternoon, sir. Today afternoon. I have sent a separate file.
That is a Word document. It is a Word document.
Word document. Yeah.
Number 2 is Gilbert. Number 3 is Vinod Kumar Kalidas. In that, at 3 number is Vinod Kumar Kalidas.
Vinod Kumar. I have the old list. So I'll go by
1, 2.
Am I audible, sir?
Number 6 is Anirban, Dr. Anirban. He has presented in the Word document.
It was last. Anirban was the last.
Can you repeat the name?
Vinod Kumar Kalidas.
Vinod Kumar Kalidas. Okay.
Sir, am I audible, sir?
Okay, go ahead.
Good evening, sir. Am I audible, sir?
Yeah. You are audible, Dr. Vinod.
Thank you. Good evening. I am going to present my proposal. Myself, Dr. Vinod Kumar Kalidas. I am from AIMS Mangalagiri.
You can
my proposal is
because your voice is not clear.
There is some.
You can switch off your videos.
I switched off the videos. Can you hear me now, sir?
Yes, your voice is breaking.
1 second.
Yes, go ahead.
Okay. Good evening to all. I am here to present my proposal. The title is Estimation of Presence of Tobacco Industries and its Direct and Indirect Advertisement of Tobacco in Social Media Available in India. Coming to the background of the rationale and background for this study proposal is, we all know every year more than 88 million people die from tobacco use directly or from second-hand smoke. To control this global health burden, the World Health Organization has brought out a framework convention for tobacco control. Under this, there are various articles are there. Article number 13 is specifically emphasizes on comprehensive ban on tobacco advertisement, promotion, and sponsorship. But it's called TAPS. As a party, signed a party of this treaty in India, India also brought on some legislations on this comprehensive ban and TAPS. Even though it was started from since 2004, still now tobacco industry is spending a lot in advertisement and promoting. And every day, the tobacco company spends over $9 billion in marketing and advertisements. It's still happening all over globally. Coming to the latest situation, the growth of communication technology and the use of internet-based mobile phones has been an opportunity to bring the TAPS through various social medias like Facebook, Twitter, and YouTube, which is more visible to children and adolescents. And recent World Tobacco WHO report on global tobacco endemic 2001, as per that report, legislation on bans and tobacco on social media has no clarity and is not included very well in many countries. Coming to Indian situation, in India, around people spend 2.25 hours every day on social media, which brings a lot opportunity for these TAPS activities. In CATS2 survey that showed that around 22% of adolescents have seen exposed to the TAP. They have seen any advertisement related to tobacco. But in contrast to that, in global any tobacco survey shows that 61% of students are exposed to TAP. That means the students are seeing more exposed to that tobacco advertisement, which is more dangerous than adults exposing to tobacco, which leads them to initiate tobacco, and it leads to the increase the burden of tobacco use. Even though our overall tobacco use is decreased in the gas survey, but overall the prevalence of smoking tobacco is not much reduced. This will be related to one of the influence by the social medias also. The reason one of the studies are done in 2014 showed that 70 cigarette brands were having around 238 fan pages in Facebook, and they around have more than 1 lakh videos in YouTube, promotional videos. This shows that the extension of the activity, direct and indirect advertisements of tobacco in social media. So to document this activity in the Indian social medias, we are trying to do this study. The objective of this study is to, among the social medias available in India, such as Facebook, Twitter, and YouTube, estimate the presence of tobacco industry. How many tobacco industries have their own profiles, and how many of them are doing direct advertisement and also doing indirect advertisement through their fan pages or through some social media influences. This is the main aim of this study. Coming to the methodology part, it is a cross-checking study. And the study will be carried out in AIIMS Mangalore, which is the National Institute of Importance. And the media we have chosen the three social media: Facebook, Twitter, and YouTube. Coming to selection of brands, identification of the brands will be done through an interview by to the randomly selected 10 tobacco vendors in Mangalagiri in and around, and we will collect a list of the brands available with them. And with this data list, we will do a thorough search in the internet on all three these media: Facebook, Twitter, and the YouTube media, to see the following outcome variables. First important one is brand promotion, whether they have any pages which is linked to their original company websites, or whether they have textual data or the video clips about the products and the product details. Next one will be a sales promotions, where there is information about their price, discounts, tax coupons, and free shippings, and anything related to the sales and sales promotion to tobacco. The third one will be the fetish imageries, like attractive young men smoking or women smoking and child smoking, or any attracted to cartoon smoking, which is attracted children and adolescents. The fourth one will be a sponsorship events, like a Formula 1 car, Formula 1 car, which is mainly sponsored by Marlboro, which is one of the ways they have promoted the Marlboro brand into the indirect advertisement to the social medias. The last one will be the presence of the misleading information, like slogans, smooth or bird, like it's flavored ones are better than non-flavored, like any misleading information will be collected. Presence of these 5 important variables will be accounted in all these 3 media and will be summarized based upon the prevalence and the proportions. The study was conducted in a 3 months period with a budget for 30,000. And the expected outcome of this study will generate evidence on the presence of tabs in social media available in India, which will be very helpful to the advocacy to implementation of this comprehensive ban and tabs, tobacco advertisement promotion and sponsorship through the social media. It should be brought into the CODPA Act, and we can bring the corresponding changes. This comprehensive ban is always a proven strategy world over to reduce the prevalence of smoking, which will help us to reduce the prevalence of smoking much better in next coming years. So this is the need of the hour, because right now the students are because of this COVID pandemic, all of them are using mobile phones, and students are more exposed to the social media. And this time it's a correct time to bring the ban on these kind of things, especially to ban the social media influencer who's doing this indirect advertisement for these companies, which lead to the initiation of the tobacco in young children. Thank you.
Dr. Vinod.
Yes, sir.
Yeah, so over to you, Dr. Bharadwaj, for question, and then Dr. Prinja.
I've got only Dr. Sanjeev asked from the previous presenter. So you have got the data in your hand. So how you are going to use that data?
Sir, that's my ultimate goal of my.
Any effect, or you can change the policy based on that data.
Yes, sir. Sir, we have a CODPA Act. Under this CODPA Section 5, we have prohibited tobacco advertisements and direct indirect advertisement in TV and movies, sir. We can brought down this. We can expand this policy and cover the social medias also, because right now we are covering social media. Because we are covering in YouTube and this Facebook, lot of social influencers, like they talk more about smoking, and they introduce new brands, and they talk and they attract the children also. So if we bring under this CODPA Act Section 5, these are social media, so we can bring a comprehensive ban on it, which is actually recommended by WHO for achieving the tobacco-free world.
It's all the law is already there. So with your finding, you will be more effectively implementing the law. Am I right?
Sir, I will cover the social media also, sir. Right now, the CODPA Act in India does not cover the social medias like Facebook, Twitter, and YouTube, sir. It is covering only films and television and the TV movies, sir.
There are many fake messages. How you are going to filter those messages?
Sir, my aim of is to show that this much of promotion activities are happening there, sir. I'm not going to see whether it is correct or bad, sir. I'm just want to show that we are telling that they are doing indirect advertisement for longer time, but there is no data to prove that. So I want to show that this much Facebook pages are there, this much YouTube videos are there to promote where, and that's the main target, main evidence to ask for advocacy against this ban, sir. Because
Thank you, Dr. Vinod Kumar. Dr. Prinja, your question.
Sure. Thanks, sir. Dr. Vinod Kumar, I think that your presentation and the proposal scores very high in terms of the novelty of the question, and also definitely the importance as well. My question is more related to the methods, that ultimately any review is as good as the search strategy and the search engines that you are using. In this context, your entire research is dependent on how good is your research of the social, how good is your search of the social media. And social media in itself has a very broad dimension.
Yes, sir. I agree, sir. We started. I have already written study on tobacco imagery in OTT media, sir. I am presenting on Monday on another conference, sir. This is a part of the next project, my project, sir, to include the social media. So at least my idea is at least to include our first 100 search for each word, sir. Pages will be searched, sir. Each search keywords, I will take the first 100 results and we will be seeing each page for these 5 important outcomes: brand promotion, sales promotion, and previous images, sponsorship, and misleading images.
Yeah, I mean, I get that. My question was only that the completeness of your search. I mean, Facebook and other things are very huge.
Agree, sir.
How?
I'm taking first 100, sir.
Can you
I'm
allow,
taking
can you
first
allow me to
100.
complete? Can you allow me to
Okay,
complete,
sir.
please?
Dr.
Sorry, sir.
Vinod,
Sorry.
please listen to the question first.
Yeah. My
Sorry, sir.
only
Sorry.
concern is the completeness of your search, number one. And number two, the indirect advertising that you are talking about could include a number of advertising that could be taken up by front organizations that have on the face of it no connection with the tobacco industry. So there is a organization called Forest, for example, which is freedom of something like that. Now that organization has no link as such to the tobacco industry, but tobacco industry funds that organization, and that industry may be engaged in advertising. So, I mean, I'm just cautioning you that you would need to take that into consideration. Thank you. Over to you, sir.
Thank you.
Thank you, sir.
Interesting study. I also repeat what Dr. Pinja said. In terms of novelty, I think it is the right thing to do. I had two basic questions. What are your study subjects? It is the cigarette brands, or it is the individual who are exposed to social media? I'm confused about that, because you gave a lot of stories about exposure of people to social media. Then you said you will pick up brands. So what is the study subject?
Sir, I am using the brands as a search keyword, sir, because my focus will be to show the tobacco industry, sir. If we search for tobacco influencers, there are so many influencers which I am able to find out, sir. But some of them they will definitely show, they are showing about some brands. So if I search using a word of brand name, I can get the any number of people who are promoting this kind of tobacco brands.
No,
That's why I'm looking the
that is
tobacco
clear, Vinod.
brands.
My next question is, we did a study in 80s on health coverage in the newspapers in Delhi. We had a clear international norm that you look at which page, upper half of the page, lower half of the page, then you measure how many centimeters by centimeters, and then you come to what is the coverage, because if it is on the front page, it gets better weightage. Is there some scale like that you will use for social media?
Sir, here we will collect the number of members, number of posts, number of views, sir. Like for YouTube videos, now there are number of views, number of likes, number of dislikes, number of comments, and number of shares. We can collect this data, sir, and we can correlate with the quality, sir.
Is it a internationally agreed norm, or you will develop one for your project?
Yes, there are few studies are done on the usefulness of video of YouTube videos. In that, we have said, sir, and in that they have used this kind of ratios, like they have called like ratio and view ratios based upon number of views and the number of likes and dislikes, sir.
Right. And then a second aspect is you're looking at. Yeah, no, I got what you want to say. My last question is, there are also positive messages on social media. You are only looking at negative messages promoted by the brand, and you will come up with saying that social media is bad because brands are using. But there are so many positive messages also going on. Are you going to look at that to get a balanced view of social media?
I agree, sir. Actually, GATS, Global Youth Survey, Tobacco Survey 4 has shown this data, but they showed that the percentage of awareness towards anti-tobacco messages are higher, sir. More than 72% of children are told that they have seen anti-tobacco messages, sir. So my worry is about the tobacco message, sir. So that's why I'm not including it, because already we have enough number of anti-tobacco messages in our media. Recent survey in GATS, Global Youth Tobacco Survey showed that 72% of children are exposed to some other anti-tobacco messages in media, sir. So they are already getting this kind of messages.
Vinod, we got what we wanted from you. Thank you so much. Very interesting study. I hope we can see the results published after you complete it. But there are some gaps we noticed. So we go to the next.
I will develop. Thank you, sir. Thank you for the opportunity.
Thank you.
Thank you, Dr. Vinod. Next, we have Dr. Anusha Purushottam. Please share your slides now. Dr. Anusha, yeah.
Good evening to the esteemed chairpersons and my fellow delegates. I'm Anusha, and I'll be presenting a study titled A Cross-Sectional Assessment of Knowledge, Attitude and Practices of Tobacco Use and Cessation Among Adolescents in the Indigenous Communities of Jharkhand. So the presentation is structured into 6 parts. I'll be first presenting the rationale, then I'll be presenting the sustainability and policy implications of the present study, the study objectives, the methodology, timeline, and budget.
Can you, we cannot see the slide changing. Can you please enter the slide share mode?
Oh, okay.
Yeah.
Sorry. Thanks for pointing that out because it was changing in mine. Let me just. Is my slide, which slide is visible currently?
Rational.
Rational.
Okay, all right, yeah. Please let me know if it's changing. Is it visible?
You can go in for slideshow.
Yes, sir, I am. Okay, I'm really sorry about this.
No problem. You click on slideshow, it should come.
Or I will share the screen for you.
Let me just share the screen.
We have also.
Vignesh, you have her presentation?
Yes, sir. I'm checking that.
It's okay.
Okay.
It's okay.
Yeah, I
Now
have.
it's fine. Now it's fine.
Okay.
Yeah, that's fine.
Okay, thank you. So coming to the rationale, the scheduled tribe community in India contributes to 8.6% of the total population, and the community itself is one of the most marginalized groups in the country. The prevalence of tobacco use in the scheduled tribe community is also higher compared to other social groups in India. It's 21.9%. Practices and other cultural practices. And adolescents, as we all understand, are more susceptible to tobacco use. And the Global Adult Tobacco Survey also has highlighted that 11.9% of the Indian youth between the ages of 15 to 24 years consume some form of tobacco. And there's a higher preference for smokeless tobacco. Similarly, the Global Youth Tobacco Survey also points towards a very high prevalence of tobacco use, with almost 1/5 of the school-going children having used some form of tobacco in their short lifespan. And the age of initiation of tobacco is 11.5 years for cigarette smoking, 10.5 years for BD smoking, and smokeless tobacco has a much earlier age of initiation at 9.9 years. We also understand from the vast global literature and literature within the Indian context that indicates that initiation of tobacco use at adolescence leads to accelerated dependency with an extremely short duration from first exposure. Early onset of tobacco use also leads to heart disease, cancers, psychological disorders, and premature mortality. There is some evidence that suggests that there is lack of penetration of awareness programs and other initiatives among the tribal youth. The period of adolescence, especially among the tribal communities, needs further attention because there is very sparse literature that is available to guide tobacco cessation programs that are tailored towards tribal adolescents. So this particular study intends to understand the knowledge, attitude, and practices on tobacco use as well as tobacco cessation in order to provide a nuanced context-specific understanding that will aid program development in order to combat tobacco consumption and associated risky social behaviors among tribal adolescents. Now, coming towards the sustainability and policy implications of this present study, the evidence that is generated from the current study will bridge our gap in understanding the drivers for tobacco consumption among adolescents in Jharkhand, which will in turn lead us to develop certain strategies within the Anamaya, or the Tribal Health Collaborative, which is a multi-stakeholder initiative launched by the Ministry of Tribal Affairs and which is supported by Piramal Foundation and Bill and Melinda Gates Foundation. The collaboration aims to improve tribal health care demand and service delivery through 3 pillars: strengthening health systems state capacity, communitization, and knowledge management and research. So the knowledge management and research vertical of Annamaya aims to assess the health and nutrition priorities of the 20 million tribal and marginalized people from 50 tribal districts in the first phase. And one of the states within the Tribal Health Collaborative is Jharkhand. High quality research such as the one proposed in this current research study will generate evidence and insights to inform policymakers and program implementers alike. Now the study objectives. We aim to explore knowledge, attitude, and practices of tobacco initiation, continued use, and cessation among tribal adolescents in Jharkhand. We'd also like to estimate the levels of awareness and participation in tobacco control activities among the tribal adolescents. Methodology, we are proposing a descriptive cross-sectional survey. The study setting is tribal districts of Jharkhand. 20 out of the 25 districts in Jharkhand are designated as tribal. The study duration is October 2021 to March 2022. Ethics approval will be sought by the Institutional Ethics Committee, and regulatory permissions from the Ministry of Tribal Affairs will also be sought. The study population, the inclusion criteria is all adolescents within the age group of 10 to 19 years who are residents within the 20 tribal districts of Jharkhand. Exclusion criteria, adolescents who have a history of systemic disease, who experience mental or physical disabilities, or who are unwilling to participate will be excluded. Methodology, we propose a multi-stage sampling strategy with an estimated sample size of 600 at a 95% confidence interval and a 5% margin of error with a 1.5 design effect. There are 5 administrative divisions in Jharkhand. 1 district per division will be selected through simple random sampling. Within each district, 2 blocks will be selected through PPS. Within each block, 2 tribal hamlets will be selected through PPS, and within each hamlet, 30 adolescents will be selected through systematic random sampling. The method of inquiry, we propose a pre-validated questionnaire that will be adapted from the Global Adult Tobacco Survey and the Global Youth Tobacco Survey. It will be modified. We will pilot test the questionnaire prior to using the questionnaire for the larger study. Data quality control measures, data collection tool will be pilot tested. The field researchers will be trained in the interview techniques, and they will follow all ethical guidelines. Data will be captured on Kobo Collect and will be stored on secure servers in order to ensure data privacy. Data quality audits will also be conducted by supervisors through field visits in a sample of the field sites. A dashboard will also be created to continuously monitor the data quality. Timeline, we propose that the first 2 months, October and November, will be utilized for finalizing the study protocol, as well as securing permissions from the Institutional Ethics Committee. The month of December is towards translation and training of field investigators. Data collection will be implemented in the month of January, data analysis and report writing in the month of February, and finally dissemination in the month of March. The budget, we have budgeted primarily for data collection and translation. We will be leveraging our existing field teams who are present in Jharkhand for data collection. Therefore, we have not created any separate budget for the field investigators or their salaries. Yes, this concludes my presentation. So thank you for giving me the time.
So thank you, Nisha. So for me it's a nice study, well planned study. But my question is only this: which risk factor you envisage for the conduction of the study?
Sir, so this is going to be a descriptive study. Although we have GATS, which looks at the entire adult population, when we look at the sampling unit for GATS, when we try to tease out the tribal population within GATS, the sample size is extremely small and we cannot make any interpretations for tribal community itself. And hence, this is a descriptive study where we are looking at the same variables that are explored in GATS as well as GYTS. So in that sense, sir, like we are just looking at simple rates of prevalence of different forms of tobacco. We're looking at the attitudes as well as the perception towards tobacco consumption among the adolescent population. So here, the age category is something that we are focusing on. And second is we're also looking at the community, which is the tribal community.
And how much can be the hesitancy on the part of participant to answer the question?
Sorry, sir, I didn't hear the question.
How can there be any hesitancy on the part of participant to answer the questions?
Yes, sir.
Tribal adolescents.
Yes, sir. So that's an excellent question, and it's something that we will have to be very cognizant of. We do not know at this moment. We do not know if there will be hesitancy because we will not be talking to just the youth that are enrolled in schools. We will also be talking to youth who are in the community. So there might be some hesitancy. If there is, then obviously, according to the ethical protocol, there will be no coercion, and we will move on to the next person in the community.
I asked this question, Dr. Sanjeev. I asked this question because we conducted such like of survey in tribal areas of Himachal Pradesh, and the hesitancy on the part of adolescent was in some places more than 40%. So that is why I asked this question. So because these tribal people, they are more hesitant as compared to the other persons. So thank you, Anisha.
Thank you, Dr. Pinja, and I welcome Dr. Sonu Goyal. He is bridging between the National Tobacco Conference, which is going on in Chandigarh, and IPHA National Conference going in Pondicherry. And the topic is covering both. Welcome, Dr. Sonu Goyal. Over to Dr. Pinja for his questions. And we will come to Dr. Sonu Goyal. If you listen to Anusha's presentation, you may have some questions. Over to you, Dr. Pinja. Dr. Prinja, you are muted.
Dr. Prinja, you are muted. Yes, now you are muted.
Okay, over to you, Dr. Sonu Goyal, till Dr. Prinja comes back. You have any questions or comments?
No, sir, please go ahead. Please go ahead. Yes.
Right. Till Dr. Prinja comes back, I have a question to you, Anusha. Adolescents are fine, they are 10 to 19, but the exposure and possibility of smoking at 10 years and 11 years is very different from exposure to smoking at 18, 19 years. Are you going to club all of them together, or what is your thought on that?
So again, that's a very pertinent question, and thank you for asking. So one of the reasons why we decided to look at adolescents and the entire age group between 10 to 19 and not 15 to 24, which is more prone towards smoking, is we would like to also look at their attitudes and perceptions towards tobacco consumption, not just the practices, not their own practices, but also their attitudes in general. And the reason we want to do that is we want to understand whether their attitudes are extremely hardwired. We understand that they can also be change agents at this particular age between 10 to 19. And this will provide us with some insights to develop certain educational materials which will help us mold their perceptions.
I got what I wanted to know. Dr. Prinja, and you unmute yourself, please.
Yes, go ahead. Sorry. So, Anusha, I was saying that one of my queries was answered when you were responding to Dr. Bhardwaj, where you said that ultimately your survey is just an expansion on the sample size of the GY Global Youth Tobacco Survey, in the sense that it has a very small tobacco tribal sample, but you will have a much bigger sample in that sense. My question was that, can you not make your study a little bit more richer by trying to explore more demand and supply side characteristics that are likely to influence either the initiation of smoking or cessation of smoking, or the quantity of tobacco that is consumed among tribal youth?
Yes, yes, Dr. Prinja. I think we can definitely increase the number of variables that we can explore within the study itself, and I would be interested to sort of expand on that. Perhaps, like, you know, if we get the technical sort of support and guidance to do that, we will definitely be able to do it. We're not hesitant, or like we're not averse to doing that yet.
Sure, thanks. Over to you, Professor Sanjeev Kumar.
Thank you so much, Anusha. Interesting study. We'll move on to the next presenter.
Thanks, Dr. Anusha. Next, we will go to Dr. Puneet's presentation. Dr. Puneet, you can share your slides.
Am I audible, sir?
Yes, yes, very clear.
I hope my presentation is also visible.
Yeah.
Yeah, good evening, one and all. First of all, I would like to thank Iphacon 2021 and also ERCTC for giving us this opportunity today. And without much ado, I will quickly go to my proposal title, that is Contraband Cigarette Availability Around Educational Institutions through a Point of Sales in Delhi, a proxy measure via littered cigarette butt collection. I am the principal investigator. I'm senior resident in Maulana Azad Institute of Dental Sciences. My co-investigator is Dr. Vikrant Mohanty, who is the professor and head in the department, and also principal coordinator and project head in National Resource Center for Oral Health and Tobacco Cessation. These are my contents, sir. Directly going to the rationale, we are already aware of the background of tobacco control efforts in India, which started with COTPA in 2003, and then India became a party to FCTC in 2005, and ultimately coming to implementation, stricter implementation with introduction of National Tobacco Control Program. India has seen multiple milestones in the last decade after National Tobacco Control Program came with introduction of film rules, introduction of national tobacco quit lines, introduction of ban on electronic cigarettes, and one of the main milestone is introduction of 85% pictorial health warning on the cigarette package, and also introduction of national tobacco quit line number on those packages. However, implementation is always a challenge, and it is undermined by certain activities by tobacco industry and the activity and the behavior of users. First of all, sale of loose cigarette is one of the culprit. Second is illegal or smuggled or contraband cigarettes across the border, which have been seldom studied in India. As per Euromotor International, around 1/4 of the overall market is basically captured by the illegal cigarettes. And when we talk about illegal cigarettes are much more affordable and popular. Why? Because they're marketed in the form of slim cigarettes. They have unique color combinations with them, unique flavors, and ultimately leading to, because of tax evasions, leading to price differential. As per FCTC, taxation of tobacco is one of the best buys, and here it is undermined. And when we talk about youth, which is already the target of big tobacco industry, and which is complex by presence of such cheaper or alternative cigarettes, the youth which have just come from schools to the colleges, they want to experiment things, they want to enjoy the freedom that they have got recently, may ultimately indulge into smoking initiation. Therefore, with this background, we are trying to assess the contraband cigarette via a proxy measure, that is direct collection of cigarette butts. Now, why we are going for cigarette butt collection in comparison with the other direct measure, for example, a survey of vendors or students, is basically it is unobtrusive, and also there is no social desirability bias. These are my aim. So the aim is to assess the proportion of contraband cigarette butts, which is out of total cigarette butts, which will be collected from multiple point of sale around higher education institutions. And apart from that, our secondary objective is also to assess the COTPA Section 5 violation at these point of sales. Going to the methodology, our study is observational, cross-sectional, exploratory study. we have taken the unit of sampling as point of sale, and because there is no previous study here, we have assumed, because as per Euromotor International, 25% of the market share is there. We assume that around 25% of the point of sale will be selling these contraband or illegal cigarette. We have devised a sample of 72. We are following a sampling technique of multi-stage random sampling, and where out of 5 campuses in University of Delhi, will be randomly selecting 2 campuses, and within those 2 campuses, all colleges shall be taken, and for each college, we'll be going through selection of 4 to 5 point of sale. And after that, when we talk about collection of cigarette butts, we'll be going to each and every point of sale, and around 10 feet of distance in all direction to that point of sale, we'll be collecting the cigarette butts. And we'll stop if there are no visible cigarette butts available around the point of sale, or our pouch is complete or full. When we talk about outcomes, first of all, we are going to assess the proportion of point of sale where contraband cigarette butts were present. Second, proportion of overall contraband cigarette butts that were collected out of total butts collected. And second is proportion of point of sale which are violating section 5. Apart from that, we'll try to do certain associations between the campuses, or maybe between male and female gendered colleges, and we'll try to see if there is association present between for the presence of these cigarette butts. Statistical analysis will be done with the use of SPSS, and inferential statistics will be obtained by chi-square or any appropriate test, right? And this is the timeline, sir. First of all, in the first month, we'll be going with protocol finalization, training and calibration of investigator and field staff, then procurement of certain material. Second and third month will be data collection, and the fourth month will be data analysis and report preparation, which will be submitted to ERCTC, and manuscript submission to esteemed journal. This is the budget that we have prepared, sir. Mainly it is for the honorarium, because the field staff will be going up out of the college hours, because most of the cigarette butts that will be present will be around 4 to 5 p.m. when the overall day has been completed. So they'll be going after the college hours, and we would be requiring water resistant seal proof bags. There will be transportation charges, and we have kept a contingency of 2,000, making it a 30,000 budget. So these are all my references, sir. Thank you so much for patient listening. Thank you, sir.
Thank you so much, Puneet. Over to Dr. Bharadwaj for question, and then Dr. Prinja.
Puneet, my question is, how is the scalability and policy implications?
Puneet, you got the question?
Scalability and policy.
So, I got the question. Sorry, there was yes, sir. Sir, what we will try is basically we'll try at 2 levels. First, at our level, we'll be approaching State Tobacco Control Cell with our report that this is the violation that is happening in Delhi, and they may take certain action. I hope I'm audible, sir. Am I audible?
Yes.
Yeah. And apart from that, sir, we'll be also going to the National Tobacco Control Program, because we can send the reports, and we can try for advocacy at our level, because we are also a tertiary care hospital. And apart from that, sir, we also have an NSS unit, that is National Service Scheme, and each and every college has this unit. And so we can rope in these National Service Scheme units of each and every college, so that they can be the tobacco monitors. So they do not allow the sale of such contraband cigarettes, and maybe stricter implementation can be there with respect to that. And this is an implementation research, sir. So ultimately, we are providing also evidence for any amendments.
My last question is, now, so you are collecting the contraband butts and the other butts. So
Yes.
Are you going to relate these with the sale of cigarettes?
It's a proxy measure, sir. Ultimately, this study, if there is certain evidence, we found that 25 or 30% of the cigarette butts that we have collected is contraband. Ultimately, this will be followed by a phase 2 study, sir, where maybe with teaming up with the State Tobacco Control Cell or any enforcement cell, we'll conduct a better study in the next phase.
Thank you, Professor.
Over to you, Dr. Prinja. You want to ask some questions?
Yes, sir. Puneet, I have a question on the, do you feel that there is any potential bias in the study design in terms of the observations that you are going to make, especially if there are different timings at which you're going at different institutions, or the level of cleanliness in different institutions, or let's say presence of bins that might be available in different institutions that may not allow you to collect any buds that may be littered around?
Of course, sir. Of course, this can be the limitation, but I'm relying on the fact that nobody is throwing the cigarette butts in a bin. So the behavior that the smokers have, they are not bothered about throwing these butts into the bin. So I'm relying on that fact, sir. And of course, sir, if there are cleanliness around if they're cleaning the campus multiple times a day, then this could be a limitation, sir.
Yeah, but this is a strong assumption. What if Swachh Bharat Abhiyan has done more better than the in Kotpa?
Of course, sir. Once we conduct the study, we'll get to know that, sir.
Puneet, I have two questions. One is, you have already mentioned, based on your review of literature, that contraband cigarettes are about 25% of the cigarettes sold. What value is your study going to add? If we already know 25% is contraband, what is additional value from your study?
Actually, sir, the 25% number that they have given is basically the numbers from the cigarette sales, right? So whatever cigarette market that the company is acquiring, whatever cigarette, the legitimate cigarette company must be reporting that our business is going down because of these contraband cigarettes, because ultimately these companies also want the contraband cigarette to stop, right? So that is the measure from that estimate. We are not getting the usability. How much users
No, that's fine. I got the answer, and very good answer. My second question, Puneet, is from the data, I don't know, pardon my ignorance, what proportion of cigarettes are consumed at the point of sale and what proportion is consumed away? And is there likely to be a difference between contraband cigarettes consumed at point of sale and away? So this is a question I have. You know better, but this is a question which came to my mind as an epidemiologist.
So this is a very well justified question, but when we talk about youth, they would not want to carry the cigarettes or cigarette packets with them. So let's just go to the human behavior, because I have been in the college, and I would not want to take the cigarette packet with me to the home, because if I get caught, I'll be all red and yellow, right? Okay. So I'm relying on that fact, sir. So whatever they are consuming is at the point of sale, and there are no studies. I have not come across to any studies like that which tells that they're taking away this thing.
Fine. Thank you so much, Puneet. Can we move to the next presentation, please?
Thank you, sir.
Thank you, Dr. Puneet. Now I call Dr. Vijaya, the final presenter, to share his slides. Dr. Vijaya?
Yes, yes. Good afternoon, sirs. Good afternoon, everybody. Am I audible?
Yes, sir.
Slides visible, sir?
No, sir.
Okay, just 1 minute, please.
Yeah.
Is it visible now, sir?
Yes.
Okay, thank you, sir. Once again, good evening to all. I am Dr. Vijay Naik from AIMS Patna, and I will be presenting our proposal, Attitude Towards Tobacco Industry Denormalization and Perception About Government's Responsibility in Tobacco Control Among Adult Population in Rural Bihar. Rationale, as we have noticed, there is no appreciable change in prevalence of tobacco use from GATS 1 to GATS 2 survey, only 6% decrease in tobacco use despite implementation of COTPA and National Tobacco Control Program. So probably their problem lies with the implementation due to various interference, and probably one of them is tobacco industry. Public do have a significant and important role to play, but often not addressed in any forum. TID, that is Tobacco Industry Denormalization, a concept in that direction. TID has shown positive impact on quitting, on intention to quit, abstaining youth from taking up tobacco use, and this has been proven in some Western countries, in Canada, and in US. In India, there is no prior literature on TID and public awareness on tobacco industry. So novelty of our study, tobacco industry is the vector in perpetuation of tobacco epidemic, and this study explored a new direction towards tobacco control, which is not done in India before. The current study will try to generate evidence how the public perceive about the tobacco products and tobacco industry and the attitude towards the tobacco industry denormalization. This study will be conducted in the community setting. The objectives of our study, primary objective, first to study the attitude towards tobacco industry denormalization. Second one, to study the perception towards government responsibilities in tobacco control in a selected rural adult population of Bihar. Secondary objective, to assess the perception of public about tobacco industry and tobacco products in the rural adult population of Bihar. It will be a population-based cross-sectional study over a period of 3 months, which will be conducted in the rural field practice areas of AIIMS Patna. Study population inclusion criteria include the adult population in the rural field practice area of AIIMS Patna, aged between 18 to 65 years. Individual must be a permanent resident or a residing in the catchment area of rural field practice area of AIIMS Patna for minimum of 1 year. Exclusion criteria: seriously ill person self-reporting under psychiatric illness, or any treatment for tobacco addiction. The sample size was calculated to be 420. We will adopt a multi-step sampling strategy. In the first step, number of participants to be enrolled from each of the 5 villages under RSTC will be decided based on proportion allocation technique. 1 adult population will be considered per house. In the second step, systematic random sampling to select the household. Next household, in case the selected household is found logged even after 2 prior intimated visits or refused to participate. In the third step, 1 eligible participant from the selected household will be selected who is available, and if there are more than 2 eligible person available during the visit, 1 of them will be selected randomly. Study tool will include 1 piloted study tool which has 3 sections. In the first section, demographic details including tobacco use behavior will be noted. In the second section, awareness about tobacco products and tobacco industry will be noted. And in the third section, will collect information regarding tobacco industry denormalization and government responsibility towards tobacco control by Ashley and Cohen, which a modified version will be using. Data analysis, appropriate descriptive analysis will be done using SPSS, and support for tobacco industry denormalization will be calculated and expressed using proportion and 95% confidence interval. We'll use logistic regression to identify the correlates of supports for tobacco industry denormalization. And this is the timeline. The project is expected to be completed over a period of 5 months. And this is the budget for that. We'll recruit 1 data collector for him, daily honorarium, then travel, then analysis and report writing, and printing for questionnaires and other materials, and totaling to rupees 30,000. Thank you.
Thank you so much. Sir, over to you, Dr. Bharadwaj, for question.
One question. What will be the policy implication by your study?
Sir, so far, as we have seen, that gets one.
You will recommend something after you conduct the study. Then what will be the policy implication?
Sir, we will know that when we are talking in different platforms, when we talk about tobacco control measures, we tell that tobacco is bad or tobacco is this thing. We inform the people, but how much that is translated into their behavior, we never check, because that depends on whether they think that tobacco is bad or not. Tobacco industry is bad.
Vijay, please focus on policy implications. This general information we all know. What are the policy implications? Dr. Bharadwaj's question is very focused.
Sir, this can be taken up in GATT survey.
Okay.
like in Western countries, it will generate mass movement against the tobacco and tobacco industry. So for that, we need the baseline data. So this is from eastern part of India. Similar studies can be conducted from other parts of India that will generate evidence that people are against the tobacco, whether they are against the tobacco or not for the tobacco. That can be presented to the.
All right. Okay, we got what you want to say, Dr. Vijay. Dr. Prinja, you want to ask a question?
Yeah, thank you, sir. So, Dr. Vijay, I think it's a very interesting study. I just had one question that
Yes,
in the government responses that you are likely to elicit from the respondents, which
Yes.
are
Prinja? Yeah, go ahead. I just didn't hear you in between.
Yes, sir. I could not hear it.
Your voice is gone, Dr. Prinja. You are not audible, Dr. Prinja.
Okay, we'll come back to you. Look at your voice. We are not hearing. In the meantime, I will ask a question, Dr.
Yes, sir.
Vijaya.
Yes, sir.
You have put exclusion criteria, and you
Yes.
have put seriously ill. What does seriously ill mean? If somebody is in the hospital, then you will exclude, or bedridden, you will exclude. That is not clear. So, can you elaborate on that?
Yes, sir. We thought of somebody who is bedridden or somebody who is not in a position to comprehend the question and be able to answer.
Good. That's good. Dr. Prinja, can you come back now?
His connection, sir, is gone. He is not
Yes.
visible now.
What do you suggest, Dr. Bharat? We wait for him, or we?
No, for 1 minute we will find him, sir. 1
All
minute.
right.
Back, sir. He's back.
Sorry, sir, I'm back. Actually, my connection
Yes,
was
yes,
unstable.
please.
Yeah,
Please.
sorry. I just had a small question, Dr. Vijay, that
Yes,
you had a
sir.
nice presentation. The topic is very good. What are the government responses towards tobacco industry denormalization that you're trying to evaluate as part of the study?
Sir, in that there is a set of questions what the people perceive that tobacco industry denormalization questionnaire. There are a set of 4 or 5 questions what the people expect the government to do to control the tobacco to control the tobacco industry. Whether government is doing enough, government should be more stringent, or government allowing some loopholes for the government officials. There are some loopholes in the system, so that government official taking advantage of that one, and tobacco industry is perpetuating its that behavior. I mean.
Right, sure. Thank you. Over to you, Professor Sanjeev.
Thank you so much. Can we disconnect all the participants so that 3 judges can have a discussion, Nima? Who is helping? Vignesh or Nima?
Yes, sir.
Who's helping us?
Yes, sir. We will do it, sir.
Yeah, disconnect all participants.
Yeah.
Or we need to log in again.
Anurag.
What do you?
No, we can do that, sir.
Okay.
We are disconnecting that. Yeah.
And let us know when we are ready.
Yes, sir.
Okay. We will start with the youngest and the brightest, Dr. Shankar Prinja. Your take.
No, sir. I mean, I'll be guided by you all. But I missed also on a couple of occasions, so maybe I may not have the best idea. But if you ask my opinion, then I feel that in terms of novelty of the topic, the relevance, and also somewhat to the design issue also, the last presentation by Dr. Vijay and the one that was trying to look at the advertising, TB,
Sir,
the tobacco advertising.
So sorry for interrupting. There is a Dr. Vijay Kumar Chatu, someone in the panel, in the meeting. can we remove him or
Yes, yes. You need to remove him because he was a participant.
Okay.
We can also request all participants to please leave the meeting. They can do at their end as well. Then we can check who has left and who is still there.
Yes, sir. No, sir. We have removed everyone, sir.
You have done?
Yeah.
Anurag Gola?
Only we are like they are our part of our conference team.
Oh, okay. So these are people who are supporting us.
Yes,
Yeah,
sir.
sorry, Dr. Prinja, please continue.
Yeah, sir. So basically, I was trying to judge based on simply the novelty and the type of the importance of the topic and the methodology that they have. I mean, I sort of shortlisted on 2, but since I missed on a lot of discussion, maybe I'll be guided by both of you. So I felt that the last presentation by Dr. Bijay and the one that looked at tobacco industry advertising were quite unique, and they were quite relevant as well. The others had some methodological issues, or so the objectives, perhaps the validity of the findings may or may not be as strong. That's my perception, but I'll definitely like to hear from Dr. Bharadwaj.
Yeah. Dr. Bharadwaj.
सर मैं तो आपको स्कोरिंग बताऊंगा सिर्फ क्योंकि बाय नेम, बिकॉज बाय नेम दिस इज माय स्कोरिंग, तो मेरे को चश्मा निकालना पड़ता है, थोड़ा सा अंधेरा यहाँ ना।
हमें चश्मा पहनना पड़ता है।
इसमें ऐसे है कि मेरे पास जो है वो नंबर 3 पर था डॉक्टर विनोद कुमार कालिदास।
बिल्कुल सर।
मेरे पास उसके ना हाईएस्ट स्कोर है, मेरे पास स्कोर्स का एक स्कोर का फर्क है बस।
बिल्कुल ठीक है सर।
मेरे पास एक नंबर 2 पर था ये मैरी गिलबर्ट, जो दूसरे नंबर पर है हमारे इसमें लिस्ट, जो वर्ल्ड की लिस्ट में है, मैरी गिलबर्ट। तीसरे पर था सर ये अनुषा।
ओके।
कि बाकी मेरा है 31, 32, 33, 34, 35 ये नंबर।
नहीं, वो स्कोरिंग में तो बहुत मामूली सा फर्क है। मेरे पास
डॉक्टर संजीव, मैंने शुरू में आपसे बोला था जो आप डिसाइड करेंगे, आई एम विद इट बिकॉज होल हार्टली आई एम विद इट।
नहीं, I'm with you, sir. Gilbert is number 1 on my list, so he's number 2 on your list. So he is common. Number का फर्क 1, 2 का ही है. It's very difficult to choose. उसके बाद number 2 में Anusha methodology wise was good, but one or two questions. Like when you disaggregate, I was expecting she's sharp, very articulate. She would have said we will disaggregate 11 to 14 and 15 to 19. That's what I was expecting, but she didn't get that, and she started going round and round. So that is why she got lesser score. Otherwise, she would have scored equal to Gilbert. So we have to give 1, 2, and 3. What do we have to? 1 and 2?
No, one only.
एक ही देना है. So Dr. Prinja, what is your thought on Gilbert then?
Sir, what you can do is, sorry sir for interruption.
Yeah. So no, go ahead.
Sir, what you can do is you can choose even 2 other proposals if we think that we can give some complementary thing to them. So we can think, but we can have one best proposal and we can give 2 complementary prizes as well.
प्रिंजा आप क्या बोलते हैं? प्रिंजा आप क्या
बोलते हैं? टास्क इजी है डॉक्टर भारद्वाज।
नहीं सर, मेरे और डॉक्टर भारद्वाज के में विनोद कुमार इज द कॉमन लिंक। बोथ ऑफ अस हैड रेटेड, मेरे दोनों ने उसको टॉप में ही रखा।
उसको नंबर 2 कर दें डॉक्टर सोनू, एंड यू कैन गिव बोथ। 30,000 रुपए दोनों को दोगे?
सर नहीं, वो उनको कॉम्प्लीमेंट्री देंगे सर, if they want to do something.
Okay, so
मेरे पास नंबर में वही विनोद कुमार था पहले नंबर पर। आपका पहले कौन था?
मेरे में भी सर वही था, और दूसरा मेरा डिफरेंट है आपसे तो, लेकिन मेरे हिसाब से कंसेंसस में विनोद कुमार तो बन रहा है सर फर्स्ट पे।
क्या स्टडी है उसका विनोद कुमार की? क्या
वो उसने टोबैको इंडस्ट्री एडवर्टाइजिंग के ऊपर करा हुआ है, डायरेक्ट एंड इनडायरेक्ट एडवर्टाइजिंग, सोशल मीडिया, वो वाला।
Right.
Okay, so you are suggesting Vinod Kumar as number 1.
I mean, आप और डॉक्टर भारद्वाज की ओपिनियन जैसे।
मेरे पास उसने 35 लिए, दूसरे ने 34 नंबर ही है।
बस तो ठीक है सर फिर।
Fine. No, I'm okay. Because there is very little to differentiate between the एक points because then individual perception also matters. So we can put Vinod Kumar as number 1. Vinod Kumar Kalidas.
Gilbert.
ठीक है सर.
And Gilbert को what do you say?
सर गिलबर्ट और विजय को रख सकते हैं, मतलब based on all of your suggestion, Gilbert and Vijay can be complementary.
बिल्कुल.
Vijay Party, I think that was also good.
मुझे भी ठीक लगा था.
Is that okay? Somebody taking notes?
नहीं, I have taken.
डॉक्टर सोनू गोयल के हाथ में गोल्डन पेन है.
नहीं, actually we need to announce.
Vinod Kumar Kalidas, he gets the project funding, and then we have
Gilbert and Vijay.
Gilbert and Vijay, yes.
Right.
ठीक है
सर. Is that okay? Everybody.
मैं अपने लिए सर कर लिया जो हमारी वैलिडिटरी के अंदर अनाउंस होगा. डॉक्टर स्तांशु अपने उसके लिए कर लें. डॉक्टर स्तांशु अभी हैं मेरे पास.
हाँ मैं हूँ सर, मैं हूँ. थैंक यू सो मच. बट ये कॉम्प्लीमेंट्री का क्या मतलब है सर?
नहीं अभी रख रहे हैं ना उसको.
सर्टिफिकेट मिलेंगे, पैसे नहीं मिलेंगे
अभी. अभी ऐसा करेंगे ना स्तांशु.
But I understand. Or Dr. Sonu Goyal can invite them for dinner at Chandigarh.
तो उससे तो ज्यादा अच्छा है कि सर उनको पैसे दे दें, वो पैसे बच जाएंगे आने जाने का चंडीगढ़ का.
Dr. Sonu Goyal takes a call.
So what you can do, Dr. Stanshu, की इनको सेपरेटली लिख लेंगे 2 लोगों को. बस आप RCTC का विनर जो है ना, एक को जो फर्स्ट वाला है विनोद, तो आई थिंक यू कैन अनाउंस दैट. एंड ये वाला क्या देना है दूसरे वाले को, तो वो हम डिसाइड कर लेंगे बाद में. जैसे फिर उनको हम सेपरेटली मेल लिख देंगे बाद में.
ठीक है, नो प्रॉब्लम. सो वी नीड द नेम ऑफ वन पर्सन टू बी अनाउंस्ड टुमारो एट द वैलिडिटरी फंक्शन. दैट इज द कंसेंसस स्टेटमेंट फ्रॉम ऑल द जजेस, एंड बेस्ड ऑन दैट वी विल अनाउंस हूएवर यू सजेस्ट. आपसे मेल आ जाएगा, उसी मेल को हम डाल देंगे कल वैलिडिटरी.
And whosoever announces says that excellent presentation, we felt like giving funding to all 10 or whatever is the number, but unfortunately we have only one available, so we had to choose which one.
सर हम ये भी बोल देंगे कि डॉक्टर सोनू के पास बहुत पैसे थे लेकिन दिए नहीं, एक भी
कंजूसी कर गए.
नहीं सर ये मतलब आई थिंक ऑल क्रेडिट गोज टू स्तांशु कि पहली बात तो कि उसने इसमें पहली बार IPHA के अंदर सेशन रखा टबैको स्पेसिफिकली का, और मतलब ये बहुत अच्छी आई थिंक इट्स ऑल हिज ग्रेशियसनेस कि इसने IPHA के अंदर रखा. और सबसे बड़ी बात है कि सर द एल्यूमिनरीज, आई थिंक डॉक्टर अशोक मेरे टीचर हैं, है ना, और डॉक्टर संजीव जिनसे मैं काफी कुछ सीख रहा हूँ पब्लिक हेल्थ के अंदर, मैनेजमेंट एंड लीडरशिप, और डॉक्टर शंकर. Always we have a cup of tea every day. तो आई थिंक आप 3 लोग हो तो इससे बढ़िया बात क्या है सर इस प्रपोजल को करने की.
बिल्कुल.
अगली बार मुझे बताना when you are going for a cup of tea, I will join you.
Dr. Sonu.
Okay जी.
हाँ जी सर, हाँ जी.
I have got a commitment if we get the conference next year, जो कल तो दे दिया उन्होंने ना.
आपको दे दिया है सर, दे दिया है, कल अनाउंस हो गया है.
हाफ डे उस कॉन्फ्रेंस में टोबैको के ऊपर होगा. हाफ डे ऊपर, हाफ डे टोबैको के ऊपर अनाउंस.
क्या बात है सर,
बढ़िया हो गया सर.
थैंक यू सर. हाँ,
टोबैको एंड बीच में दोनों की कोलैबोरेशन.
हाँ बिल्कुल बिल्कुल.
राइट सर.
Congratulations to both of you, Dr. Sonu Goyal and Dr. Satanshu Kar.
Thank you sir.
Thank you sir. I think अभी डॉक्टर श्रीनाथ रेड्डी बोल रहे हैं अभी दूसरे सेशन में. मैं एक्चुअली देखो ये वाला चला हुआ है एक्चुअली हमारा जो सेशन है, तो अभी डॉक्टर श्रीनाथ रेड्डी और मैडम प्रीति सूदन का चला हुआ है अभी यहाँ पर.
बढ़िया सर.
थैंक यू सर.
Thank you sir.
Thank you everyone sir. Thank you.
Sir, let me thank
Dr. Dr. Prinja again.
Sir, thank you so much to all the 3 distinguished judges. One is Dr. Sanjeev Kumar sir. Sir, the pre-conference workshop was very well taken, sir. Thank you so much, and for this activity also. We missed you during the Central Council meet also yesterday, day before yesterday, when they talked about the Indian public health, what was that? Garden. Yes, sir. Yes. Then Dr. Ashok Bharadwaj sir, thank you so much. It was nice. We wanted to have you here, but आजकल वो कोरोना की वजह से नहीं हो पा रहा था कुछ. And Dr. Shankar, always a dear friend. जब भी बुलाओ तो सब कुछ मान जाते हैं.
मुश्किल से मानते हैं, ऐसे नहीं मानते हैं. He is the most busiest person on this earth.
You don't have to feel bad, Dr. Sudhanshu. Send me an open ticket. I will come when I can.
Yes, sir. Yes, sir. Definitely, sir. Definitely. But please keep in mind that this is all being recorded. So
it is on record.
It's on record. Thank you so much, and thank you, Dr. Sonu, and thank you, RCTC, for instituting this award. It is really a good thing to do. We should, as this is our responsibility to promote research in specific areas, and if we don't do it in a national forum, it is not going to do. It is not going to happen. So this is our responsibility and our commitment as well. As Bharadwaj sir just said that next IPHA will have half a day workshop or something related to tobacco. This is a very good initiative. We should give importance to all these issues which are of public health importance. And thank you so much for doing this. Today we finished the 12th, 11th plenary of our day 3 of IPHA. Tomorrow is the last day. Then after that we'll move to NC. Then like Dr. Sonu's, I could not log in also, but thank you so much for all this help and all the guidance and all the support. Thank you so much, sir. On behalf of organizing team, thank you.
Thank you.
Thank you.
Okay.